1970 from Lady Hardinge Medical College, and then she has been serving Maharashtra and India. She worked in Grants Medical College and then in heading the Department of Neonatology in KEM Hospital, St. GS Medical College. After she retired from there, she has continued to serve as a professor in D.Y. Patil University. She has been the pioneer of KMC along with Shashivani Madam. She has been one of the teams who went to Bogota and got trained in KMC, and she came back and established Kangaroo Mother Care and did a lot of trainings across India. She has been instrumental in making me do the randomized controlled trial, and since then she has led not only
first of all, I must say, addition of this donation to our program, and today we have a very illustrious person who has done a lot of work in Kangaroo Mother Care promotion, and as an innovator and so on, other things. So, the first credit is he describes himself as a human being, and he aims to be a good human being, and he has proved to be one. So please give him a very good hand, and now he will go for his formal introduction.
Thank you, ma'am. So just continuing up with the introduction, and it's a very long one, so I will be from Western Medical College in Bihar in 1998, and followed that internship with in the same college and in Safdarjung Hospital in New Delhi. Completed his Masters in Public Health in 2002 from the Bloomberg School of Public Health, Johns Hopkins University in the US. Following that, he has led a lot of innovations, and he began the Shivgad Living Lab in Shivgad since 2002 till present, of which is the founder and researcher. He was the director of the Johns Hopkins King George Medical University Center for Maternal and Newborn Health, investigator in the Transition Host Institution of the Community Empowerment Labs, various courses that were founded in 2009. He is the founder, CEO, and the principal scientist of CEL. And since 2020, he is now the founder and the chief scientist of Community Empowerment Lab in Lucknow, UP. He has in assisting KMC, and I will quickly go through a few research projects which have been conducted in collaboration with national and international agencies, including WHO, UNICEF, and so on and so forth. So the sugar slides, but specifically if you can look at the ones in KMC, there was the Kangaroo Care Implementation Research and which was designing and evaluating a scalable model, which began in 2016. and as Dr. Suman mentioned in a presentation, they are going to be looking at the IKMC scaling up and implementation in the next few years, and also developing various models for comprehensive primary health care and innovation and learning centers. They change the way in which KMC is seen, especially in UP, where they introduced lounges, and which was the UP Kangaroo Scale Up program, and they included self-help groups and various community settings for ensuring that this happened in various sectors like epidemiology, community systems and health systems, and a lot of citations to that. He's received honors and awards from various centers, from UP management institutions, from Asia, even from the KMC Foundation in 2017, and also various gender equality, social work, and community empowerment awards. One of the things that we look forward for maternal and newborn health, it was the first district with universal kangaroo care coverage in 2018 from the KMC Foundation when the conference was held in Lucknow, accelerating kangaroo care adoption in Agrima. With this, I request Dr. Vishwajit Kumar to please go ahead with this presentation. Thank you very much. A big round of applause, please.
Thank you, Professor Vani. आप नीचे बैठना है. आप बैठिए, आप प्लीज प्लीज प्लीज. जी जी जी. Thank you so much for the kind introduction. I'm not sure if I'm worthy of this oration, but there is no way I could have said no to this invitation, and it's all to do with a mother. My mother was a very strong woman. I wasn't fortunate enough to spend a lot of time with her. Maybe that was one of the inspiration that for the past 20 years I have been focused in trying to bring science to improve the state of our mothers and newborns. The third, of course, is in our culture, a guru has a much higher pedestal than anyone, and the Guru Ma, Professor Vani and Professor Udani. And not last, but very close to my heart, and I'll say this in Odia, Odisha Mora Matrabhumi. This is also my motherland. So this is, and so just the affection that I have received over the past 20 years from many of you who are my seniors, my teachers, Professor Nangia is here, doctors, I won't name just one because there are many of you, both within this room and outside, and I am deeply honored and deeply grateful. And thank you so much. I think thank you, Professor Somshekhar, for the introduction, but I am just another simple human being, madly and obsessed with trying to do my very best to do whatever I can do for my country, particularly with a focus for its mothers and newborns. I believe mothers of all species are divine. There's nothing absolutely comes close to it. And I'm very fortunate and blessed that that's the path that I have chosen. And so in the next, I'll try to make this oration as less painful as possible. All of you would be waiting for lunch. And so I'll essentially just talk about our journey, because I've just been a very small part of that entire, whatever we have been able to achieve, I've been a very small part of it. But absolutely fortunate that I'm able to represent and be here on behalf of everyone. So this is around kangaroo mother care, and I say it's so close and yet so far, and I'll just take you through. So the next set of slides, some may be redundant in some form or other, but let me still repeat it. And the question that always comes, at least I have faced over the past 20 years, that why should we even be, as I speak, this is a difficult time for me personally because my brother is battling cancer and it seems he's losing the battle. And for me, that one life means the world. And so when we look at numbers, particularly as epidemiologists, we get desensitized as policymakers, as we just somehow end up each of them being numbers, but they're not. Just like for me, my brother is my world, and therefore these 170,000 newborns that we lost in UP in 2022 were not just numbers. Behind every number, there was a mother, there was a father. Moral imperative for us. This is what humans need to do for each other, particularly when we know how many of them die, we know what they die of, and we also know that over 70% of them can actually be saved. And they don't need to be intervened. We just need to felicitate that. We just need to facilitate them so that they are able to do what they can, whether it's breastfeeding, whether it's hand hygiene, whether it is care seeking. There are many things that they are capable of doing. We just need to help and support them and empower them to be able to do so, and we should be able to do that. In UP, if I give you an example, time we lost 170,000 newborns. And there is a difference as well, because these 170,000 will keep repeating with some minor changes year after year after year. And so I don't think it's a question, I think it's more a reflection about who we are together than it is about those newborns. And so these are some of those key questions that I would urge each one of us within the room and outside the room to be thinking really hard. Now, one of the ways that we have at least adopted is bring hard science to solve some of these actually very serious humanitarian challenges. And so these are data from UP. Just in UP, for example, 2/3 of all newborn deaths occur in low birth weight infants. I won't go further in detail into this, but that's the key message. And so one we know we can prevent, the other we know that 2/3 of them are all newborn deaths, are low birth weight, but also remember there is also 1/3 that are not low birth weight. So we have, our challenges just spans across. And then if I just move to KMC, that has been the focus of this conference, is when you look at KMC, I will just reiterate one thing because you know the data probably better than me. A study that was done thanks to Dr. Rajiv, Dr. Suman, and let me actually call out Dr. Chelani and the others from the different sites, Dr. Bergman, Dr. Ventro, they have been absolutely catalytic and pivotal in trying to answer one of the most key questions is about unstable babies. And so when they did it, unstable babies compared to stable babies, you again saw a 25% higher survival. There is almost no other intervention that I can think of. It's not actually an intervention. I would let you. And thanks to many people in the room here, thanks to the leadership of the government of India, and thanks to the global leadership, that India actually has been one of the key countries, one of the foremost in actually adapting the every newborn action plan for our country. And we have, as a country, signed up to achieving 90% coverage of kangaroo mother care by 2030. So we only have 8 years left. And so we have to achieve, this point we are less than 5%, and we have to achieve by over 90% by 2030. And so and this timing of this KMC conference is so pivotal. And it's early in the year, so we just have 8 years. So from here, I think every KMC conference, I think it should also be a countdown where we come and report back what we have achieved for our babies. And therefore, kangaroo mother care becomes very pivotal for a country like India, and particularly for a state like UP and Orissa and many other states. If we are able to take this to 90% of our babies who are low birth weight, we should be able to cut down neonatal mortality by 1.1 lakh. So that's a huge impact to have, and that is well within grasp, and yet it is really far. Now all of these, as we talk now, and thank you, Dr. Suman, for providing both the leadership in very proactive. I don't think we have shown commensurate will to be able to utilize the policy environment that exists to translate it to real changes in KMC for babies. So let me go back and let me take you back to 2003. I used to be a faculty at Johns Hopkins University, and with another senior colleague of mine, Gary Darmstadt, we decided that we need to be focused on trying to understand and find solutions for newborn survival in low-end resource settings, and that's what brought me to UP. Now, this is 2003. This is Shivgarh. This is one of the blocks in Raebareli district in UP. At that point in time, and every household was surveyed for newborn mortality, and the newborn mortality prospectively was 84 per thousand. So literally almost every 10th newborn was dying within the newborn period. Now, and at the same time, when we looked at it further, we found that there were a lot of high-risk practices. So this is the context that we were in. At this time, I also have to acknowledge and thank and be grateful, and I think for Dr. Abhay Bang. By this time, he had already completed a very important study several years ago, actually, by the time I started, which is popularly known as the Gadchiroli study, to actually bring it to home. So he had a very intensive program to train women in the village on active sepsis management, resuscitation, etc. And he was able to demonstrate through a quasi-experimental study that you could cut down mortality by 70%. I think that was one of the most pivotal moments in community health. We started with a very different question. We were like, we don't have a health system, we don't have health workers, but then what do we do? Should we wait for hospitals to be there? Do we wait for pediatricians to come in? Or do we answer this key question is, do mothers have? We had very limited resources. I literally had very limited resource to do this study, and I look back, I think it was a blessing in disguise. And so this is, as you may have seen, I've grown older, I have gained age and gained weight. And so this is way from 2023. Now we spent time in the village, stayed there that's where I used to stay. And we realized that every mother, I didn't realize as part of the study, but we know that every mother, or whatever practices they were doing with one simple goal, that they wanted to save the life of their baby. And so we went about, they were actually putting the babies at increased risk. And so, which meant that there was a possibility that if we were able to modify some of their behaviors and empower them with some skills and tools which didn't cost money, and then see through a randomized controlled trial if they could actually reduce neonatal mortality. So we created a small package, an essential newborn care package with kangaroo mother care at its heart, and skin-to-skin care, breastfeeding, cord care, etc. And we ran this trial for 18 months. But why do they do? And then tweaking it so that they could adopt some of the new practices that we wanted, we believed would actually be helpful. So one of the first things was to make sure that, for me, just babies, I believe that I was probably the least important stakeholder, and therefore what I felt was not the most important. You had community leaders who were gatekeepers, you had families, and you had other people in the community who actually were far more important key stakeholders. One of them was known as a doman, an untouchable woman who actually used to cut the cord. We did not replace anybody, we did not substitute anybody on care practices. We did not have the money to spend on expensive information, education materials, but we used simply storytelling to inculcate them within their culture, and therefore we call it enculturating science. And we had a universal adoption of 85% of all newborns. They provided KMC in the community. We are talking of the pre-NHM era. And we saw a 54% reduction in neonatal mortality, and with a 71% in breastfeeding initiation. This was so stark that it took, I feel, it was more than a validation of what we had done. Here they were only looking at kangaroo mother care and had over 30% reduction. Such is the power of, and such miraculous is its impact. Now this was, once we had it, as you would expect, the whole enthusiasm within us and within the policymakers was just that we need to now scale this. We are very thankful to Melinda Gates, who actually visited, and in her book, The Moment of Lift, she writes very generously about us, and we are very grateful. So, and I think one key thing is, it is not just the delivering the science, but it's also important. It's just not the science is important, but how you deliver the science is equally important. And I think that's, I believe, we started with this bang, and then from 2008 to 2017, we started the process of what we call UP Comprehensive Child Survival Program. There was a dynamic administrative leadership in UP. They wanted to scale this. We also, thanks to UNICEF, we had created a composite IMNCI plus infection management and behavior management, and we rolled it out to 1.8 lakh ASHAs. That's all that we did. It had absolutely zero impact. We trained all of them, they went back home, and they did absolutely nothing. And so that was our first, that was proved one thing, that if you have a well-designed package, you could actually, families could actually use that package to save the lives of the newborns dramatically. How to do it? Can that be done by the health system? That was not the question that we answered, but we went around trying to scale it, and we absolutely, utterly failed. There was another very important study that I was the co-PI with, Dr. Somshekhar just mentioned. It is the Better Birth Study, a big, well-funded, $20 million. And that study was after this debacle. I was like, maybe there is another way to do it. So let us just do as the global health community does it. So you have nil. There was no, it was an intervention that was a checklist of some 15 key interventions that you would do before delivery, at the time of delivery, and before discharge. It had zero impact on mortality. Skin-to-skin care was also part of it. So just having an intervention is not equivalent for that intervention to actually become a practice. Scaling is not impact. And so this was very important because it actually helped us realize that we need a bridge from a proof of concept to implementation. And thanks to WHO and putting up. Now this, as Dr. Suman mentioned, I think one of the key things that I keep mentioning is, I think one of the important things is challenges are important. There are two ways that we can actually confront challenge. Either we succumb to it and say it's too difficult to actually do it, or we take it up as a challenge and say we will show you how to do it. There is a way to do it, and let's figure that out. And so the challenge was that we had the policy in place, we had the money in place, but we just did not have a implementable model. We had the intervention, but not the model that could be implemented by our health system. And therefore, and this was the context where a mother and the baby is kept separate. And we were set the target of achieving greater than 80% coverage along the continuum, within the facility and at home. And I was one of those people who were like, this is just impossible. There is no way we can do it. But then Dr. Rajiv was not definitely willing to listen. And I think thanks to all the other, Dr. Suman, other investigators, I think we took this challenge up. But we knew that if we had to achieve a coverage of 80%, which had never been achieved before, we needed. And so we changed the way we looked at it. Instead of keeping the newborn in the center, we actually said, let's keep the mother in the center. Because if you look at all the miraculous benefits that many speakers have mentioned before of kangaroo mother care, it is not because of the kangaroo. It is, all of those are simply harnessing the power of the mother. And therefore, we needed to make sure that if we were expecting a mother to provide kangaroo mother care for 18 hours, 16 hours, or at least greater than 8 hours, we needed to create a ecosystem where she felt desire. I work in UP, I don't know how many of you have worked, but I have no qualms in saying that this is one of the most difficult geographies in the world. And therefore, we were like, no, we need to make it something that it becomes not just an intervention, but a cultural artifact. Can we help start making a cultural change there, where mothers are respected, where a message goes to everyone, from a doctor to a nurse to everyone else, that the mother is important. If KMC is a religion, then that religion better have a temple. And this is what we wanted to build. We then made some further modifications. We said, well, if KMC being a new innovation, and KMC nutrition, we added KMC respect, KMC monitoring, and KMC hygiene. Because these are also practices that actually puts our baby to increased risk. So here we were using KMC as an engine, and these were other bogies that were attaching to it, so that we could get a synergistic effect. And the second piece important was, in order to make sure that we are able to understand that we should not break the KMC chain. And therefore, right from initiation to SNCU, to the lounge, to the transport, to home, this chain should not be broken under any circumstances. And so we had the lounge at the center of it, thanks to the National Health Mission and both of UP and this. They also actually sanctioned a position for KMC nurse at this. We had job aid and protocols that were designed grounds up. And the last, of course, is data-driven governance. So use data that was being collected to drive decision-making at the facility level and also at the district level. Because this was a unit of implementation. The whole idea is, if we can have a district as a unit of implementation, we should be able to replicate that across the state. And as I said, this was not just facility, we also had community, and we had a few innovations around that. One of them was just having a home-based, it was integrated with home-based new care, having a voucher where the mother used to get the voucher that she would then give to the ASHA when she makes those visits. Integration with RBSK, and also a 24/7 helpline for the mothers, nurses, and doctors. So here, when you are out there in one of those faraway villages, you know that if you need any support or queries on KMC, you're just a call away. These are, we had other sites in India. Dr. Suman was from Karnataka. We also had Haryana, and we also had African sites. And these are some of our site-specific paper, and this we publish in BNJ. Won't go further, but I think we were very close, or maybe we did exceed funding support. This was implemented by the health system with most resources actually coming from them. And so, to answer the question, can we actually do it? Yes, we can. Is there a way to do it? Yes, we have. Does all the model have to be the same? No way. Karnataka had a slightly different model, Haryana had a different model, and I think we can adapt, and this implementation science provides us that opportunity to adapt them. I will not go further here, but just all to say that when you also implement KMC, you actually strengthen the health system. Let me begin by just one thing. When you have the mother also become a provider, you just have expanded the number of health providers to include every mother. Why isn't mother become central to the care of the newborn? So every mother becomes a very central part of the care team. And I think for a resource-poor country like us, a resource-poor state like us, it makes a huge difference. The other is, if this is on the first slide, the first one that you see these big peaks, they are actually from the records of probably thousands of birth weights being taken within these hospitals. But once taking a birth weight is so key, it's so fundamental, so pivotal to the care that you will provide them. And therefore, if you have to provide KMC and you need to make decisions, you need to weigh them right. So once you start implementing KMC, the graph completely changes. All that it shows is the quality of the birth weight, the taking of the birth weight increases dramatically. Let's go. There's one key findings that we had from UP, I think that is very important. We had implemented in the district hospitals, we implemented in the community health center, but we realized that actually in the district women's hospital, the community health center actually performed significantly better. And there is one reason for it. When we did a qualitative work on this, we realized that for community health centers who now were only referring the babies, they felt that once they had this whole package of care available here, they started to initiate care of those babies right at the community health center. And as you would know, the number of SNCUs, if all babies were to actually come to a sick newborn care unit, only 10% of the babies would actually get care. And therefore, we need to make sure that we have to rationalize care by where they are. And so they actually felt, for them it was aspirational to do kangaroo mother care. For the sick newborn care unit, for pediatricians, it almost seemed that from allopathy they have started to do naturopathy. It almost seemed that they're downgrading themselves. And I think this is one thing that we have to work together, because the evidence is overwhelming. And I think one way to do it, you just do it and you will realize you just have a high quality data collection, and you will see the evidence will speak for itself. So I think there are some barriers that we need to overcome here. This is from an equity perspective. When we look at SNCU data, we had more babies, these are from UP, more male children actually got care within SNCU than girls. But within the KMC lounges, we don't see that difference. And part of the reason is When you put them to a sick newborn care unit, there are times that you have to make decisions and people can then start differentiating. But here when you start KMC right away, it actually tends to blur those discriminatory behaviors even if it emerges. This was what I talked about was when we attempted to do it as part of an implementation research in a district. But now the question is, we need to scale up. One thing that we did with UP while we were doing this implementation research with the government, we did not wait to actually also begin to scale. And so now I will, the last section of it, I'm going to just talk about the scaling up. We realized that just doing it one facility or in a district, scaling is not just multiplying that by 70 districts. You needed a very different order of innovation for KMC to sustain at that large scale. So what we did, we developed a KMC app. It's actually not just an app because all the apps are connected with each center, so it's actually creating a digital ecosystem which then provides that kind of a scaffolding for all of them. So this app again was co-designed with pediatricians and with the nurses, and this has a EMR, this has a clinical care module, it has module for family counseling, and it has lounge services. We have developed this over several iterations over several years actually. At this point in UP, we have 233 KMC facilities where there are 8 districts where from community health center, every center KMC is being provided. Out of which there are 203 which have KMC app deployed, which essentially means that we could actually sit from here, know what is the status. The commissioner of the division would know how the different centers are performing. The principal secretary health has a visibility in terms of how they're performing across. However, these apps were designed, we are very careful that we are not designing these apps so that we make them visible and vulnerable. No, because once you start measuring them, they start lying because they fear that they do not put spurious data, then there would be punitive actions would follow. So we were very clear in our understanding with them and with the government that no, this is an empowerment tool and no data will be used for any punitive action whatsoever. And therefore that has initially took some time to build that culture and dispel fear. As I said, this is the timeline of how we started, and we are now over 233, and it continues. All of these scale from, except the first one, all the rest of the lounges are entirely funded by the government. All the apps, all the tablets, everything else is absolutely either funded by the government or in many districts with CSR partners. We also had the first MNCU in India, in UP, and this was in Badaयूं. Many of you would remember that Badaयूं actually is a district very infamous. There were 2 girls who were actually raped and they were found hanging from a tree. This is the district. Now this district has completely changed its reputation when it became the first district to actually have an MNCU there. And they were done entirely with district funds. So we have also, in order to, and as I said, when you're doing it at a state level, you need a different order of innovation. And therefore what we have now is a KMC ranking parameter where each facility keep graduating to higher levels. So, and they're not very difficult. It's like a game, and you do, for example, the level 1 is KMC lounge and app are regularly used. There is good coordination with the labor room. They have robust processes, etc., etc. And then the last one is also taking a feedback from the mother. So we are able to create a 360-degree feedback and a motivational matrix so that each of them are able to inspire each other to do better and hold each other accountable as well. So this is the ranking. So each facility would be somewhere in the rank, and they share and they are ranked, so they gradually work towards improving their own ranking and competing. This is just an example of facility performance dashboards, which is regularly shared at the district and the division and at the state level. Now, the last one piece is just, I think they're all important, but once you're working at scale, we have to recognize that it is everyone has to win. Just the mother winning is not enough. Just the pediatrician winning is not enough. Actually, everyone else has to win. So for example, once we have this lounge and we have this MNCUs and we have these apps and we have all of these moving on, then it also makes the health minister look good. It helps make the chief minister look good. It makes them everything so visible. It makes the health facility look good. So now whenever the chief minister goes anywhere, the district administration ensures that the chief minister does go and visit one of the lounges. And so that has actually created now a whole a kind of motivation for districts to start saturating and providing to everyone. So this ownership is very important. It cannot be, as I said, my stake or our stake is not the highest. There are other stakeholders in it, and they need to win as well, and they need to be part of the equation. This is, they put KMC on their annual, set of achievements, and this had probably 30% of the space that this is by the health minister. The administrative leadership. We had all facilities were inaugurated. We had the administration from principal secretary downwards. They're all part of the milieu. And then, of course, community ownership, for which we want to do it. And then you have health system ownership. In many cases, you'll find that the nurses actually start giving the KMC. So, and media, for example, they may not have a direct impact, but if you look at vaccination hesitancy, etc., then you realize that it is very important that we need to engage them early on so they are able to create an environment that is conducive. And so these are just some of those. But then I will actually end by saying that KMC is not just about us. That us has to be expanded to include every key stakeholders. I think we need to answer a question, what's in for them? And I think once we start developing solutions that also gives them the benefit, I think we are able to then create an ecosystem where a lot of people come to support. I will now end this as the last slide, and I say, as you would see, this was 20 years of our journey. At this point where we are, we don't think that we are driving the scale up in UP. It is the district administration, it is the divisions, it is driving those innovations. But wherever we are, all things are very difficult to begin with. But then once we are over the hill, it actually becomes easier. I am hoping that we have now come to a stage where now subsequent expansion will continue to be easier than it has been so far. Thank you so much. Thank you for this honor, and I remain ever grateful.
I request the organizers to bring the plaque and the shawl. Can we have the lights, please? All the lights.
All of you would agree that what an excellent presentation it was. Presentation reflected the work which has been done, and we have an excellent presentation. Thank you very much. And on behalf of KMC Foundation and on behalf of Professor Rekha Innovation, please accept this memento. And I request Dr. Prabhakar to do it. Thank you very much. He has given us many messages that even as an individual what best we can do, building up a whole team. So it is just teamwork. Sorry, we are running late, so we will go to the next program here. That is the plenary session of our KMC Foundation. Every year, we have one small slot in the conference where we reflect some of our activities also, and also we will take up some of other projects. First of all, I request the KMC kids to come over the stage. There were a few KMC kids, please come over. Anyway, please they come over. Yes, yes, they are here. Please. It is our pious custom that we always have one program with the good wishes for KMC. Just आपका नाम बोलिए. ओके, आपको पसंद है यहाँ आने का? Now I request Dr. Sumita Ghosh, Dr. Vivek Virendra Singh, please join us on the dais. इसका नाम क्या है? दिया चला?
I request Dr. Arijit and Dr. Samarendra Mahapatra and Dr. Parag Dagli to join us on stage.
Dr. Vishwajit,
Dr. Kharod, Dr.
please
Kharod
join
also.
us. I request Dr. Kharod, Dr. Parag, please join us on the stage. Yeah? Okay.
गुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते
Take it back.
दीपज्योतिर्परब्रह्म बुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
I request Dr. Arijit to give the welcome address.
So, very good afternoon to all the dignitaries on and off the dais. It's my pleasure to welcome the who's and who of KMC in India and of KMC Foundation. And as Professor Sasivani told that, this is in the KMC Foundation and KMC conference, we always have a small plenary session where the key opinion leaders and the senior leadership from all the organizations, the government, the NGOs, the research organizations, the policymakers like IAP, NNF, KMC Foundation, and breastfeeding promotion are all get together onto the stage and pledge for development of KMC in India to further the cause of neonates in our country. And we are fortunate today to have senior personalities from UNICEF, Dr. Vivek, and from Government of India, Dr. Sumita Ghosh, to be with us. So I welcome all to the plenary session of KMC Foundation. I now hand over to Dr. Somsekhar to conduct further.
I invite Dr. Kharur to please invite from KMC Foundation.
In a way, it is a milestone because 2012, the international conference was held, and I think the seed was sown there. Years, and this conference, I think every year we are seeing evolving into a better shape. It indeed gives me pleasure on behalf of the KMC Foundation to welcome everybody, and it is very important to get the support that we are getting from the top officials of the country. So we are becoming more and more confident that this we will be able to promote over the country in a better way. I am very thankful to Sumita Ghosh for gracing the occasion and also the entire team which has very nicely organized this event. So it gives me a great pleasure welcoming you all to this function. And now I hand over mic to Dr. Somsekhar to tell you in brief about the activities of KMC Foundation in last 1 year.
Good afternoon, everyone. We are on our final day of the KMC conference, and it's a pleasure to present the annual report of the foundation to you. As Dr. Kharot said, we began post the International KMC conference, which was held in 2012 in Ahmedabad, and we are a voluntary non-profit service organization where we promote all activities related to newborn care, specifically Kangaroo Mother Care, with our office begin in Gujarat. Our main mission is to make the mother's chest the best place for the newborn care, and mother's milk as being the best food for the newborn, and also to ensure that there is zero separation of the mother and baby. We want to make, as Dr. Vishwajit said, to make it a cultural part, so as a part of routine care of all newborns, especially the low birth weight babies, and not to be considered as something separate. So while we are an organization which looks as promoting Kangaroo Mother Care, we don't want it to be seen as a separate part of newborn care. And one of the main ways we go about this is to ensure that we do advocacy and demand generation in public and policymakers, and hence you see UNICEF and the government being part of all programs of Kangaroo Mother Care Foundation. Try and do capacity building across all categories, doctors, nurses, home-based newborn care in NGOs, etc. And also support some relevant research studies and ensure accreditation system and quality improvement. So these are various objectives that we have at the KMC Foundation. We have created this training materials long back, and we use them in our training programs, and which have been well appreciated in most of the training programs. In 2017, we began our annual conference, and this is the 7th one, which are based on various themes. The first one we had in Hyderabad was in 2017, we looked at improving quality and coverage of KMC, improving horizons of KMC practice in India, in Lucknow, and we looked at ensuring there is a continuity from facility to community in Ambala. In Jaipur, just before the pandemic started, a month before, we had this conference where we focused on quality, equity and dignity of KMC in India. In 2021, we had an online conference where we focused on early childhood development and contribution of Kangaroo Mother Care to early childhood development. Last year in Bhopal, we had again time to translate evidence into action and keeping baby and mother together. And this year we are looking at reaching the unreached, and which actually has been quite a issue, because we have seen in Orissa in the last 15 years the tremendous development that has taken place in improving coverage of newborn services and now KMC services to various places. So these are conferences that we had, and every year we try and involve various other organizations and get them to support Kangaroo Mother Care. So we had National Immunology Forum, IAP, FOXY, ISOPAB, etc. in 2017, as you can see on the slides, and then subsequently every year we looked at IAPSM, Developmental Pediatrics Chapter, Indian Association of Neural Nursing, Indian Medical Association of India, and many other organizations which have pledged support to Kangaroo Mother Care. In 2020, we had IYCF chapter, the Medical Council of India, and Dr. Ramji was present at that conference, and subsequently last year we have had International Pediatric Association, COMAD, who have pledged support to introducing or making Kangaroo Mother Care as part of their programs. And this year we will see other organizations do it in a few moments from now, which is Association of Pediatric Neurology, Association of Child Neurology, and Ayurvedic Association. We have done various issues like we ensure that there are stamps, training videos which are made. We are made in multiple languages, and yesterday we would have seen the release of the Oriya module which was there. We have covered most of the country, including the Northeast, and in the north, extreme north, where we have conducted KMC training programs. We have a quarterly newsletter which reaches out, and if you want to be part of the quarterly newsletter and if you want to share what you're doing in your KMC program, you can reach out to us at kmcfindia@gmail.com. A few days that we definitely do organize awareness programs, as you shall see in the subsequent slides, newborn care program, breastfeeding programs, and KMC Awareness Day, where we do extensive programs with various associations. We have also been, since 2021, we are the secretariat of the Asia Oceania Network of KMC, and we are going to be continuing to do one again this year. So generally it's a two-year secretariat, but this year they allowed us to have another year because of the pandemic, and they have been part of many of our activities over the last 2 years and will continue to be part of the activities this year too. And as I mentioned at the start of the oration, we have had this Dr. Rekha Udani oration since 2019, and various activities that have occurred in the last year, in the preceding year, was the conference where we had time to translate evidence into action, where International Pediatric Association and COMED pledged their support to KMC Foundation. We also had the Minister of Health from MP inaugurate that session. These are pictures from various workshops that we had conducted there, and we had these two specific new workshops that we conducted last time: role of obstetricians in promoting KMC in India, and immediate care for sick and small units in MNICU, which actually began as a program in November 2021 during the newborn care week, and it was well appreciated, and we continued it in the next conference, and we have had it in this conference as well. So these are our workshops that we have held in the last conference. In the last KMC Awareness Day on 15th May, we had one program with National Neonatology Program, which was organized over a period of 3 hours, when Dr. Vishwajit also spoke during that program. We had again on that day we had a program with KMCF and Asia Oceania Federation, where we had presentations from Malaysia, Cambodia, Philippines, as well as from India. So this was a very interesting workshop, that the online CME that we had. We also conduct programs with other networks like NNF Gujarat, other universities, and this was during the KMC Awareness Day on 15 May. So again, this year we'll be organizing, and if anyone wants to be part of it, you can get in touch with us. Again, World Breastfeeding Week is another time where again we get into we kind of conduct awareness programs. So we had an Asia Oceania Network for KMC Care, along with whom we had this program on 5th August, where Dr. Sushma Nange and Dr. Shahidullah from Bangladesh moderated the program, and we had presentations from Mongolia, Malaysia, India, Nepal, Philippines, and Vietnam. So again, it was a very interesting program which went on for around 4 hours. We also work with state governments, as we said, and Dr. Kharod was invited for a workshop with the Gujarat state government, where we had ensuring early initiation of breastfeeding. We also are involved in home-based KMC promotion, and along with Nutritional International, we have had various workshops done in Gujarat, and in November we had many of our members had participated in the international KMC conference. So we saw Dr. Suman Rao give a lecture today, and which was actually one which she delivered at that particular conference. Dr. Deepa Banker spoke on COVID experience in Indian neonatal units at the international KMC conference, and Dr. Shashi Vani spoke on dissemination of KMC in India and its implications. So these are a few pictures from the international KMC conference that was held in November in Spain. Okay, so this is Dr. Vani, and these are our Indian delegates along with Keka Pelas from Spain and with Natalie Chapa. So we are creating a certificate course in Kamera Mother Care in Gujarati, and this will be a very interesting thing and this is aimed at nurses and other providers. There are various activities by individual members where we conduct courses during breastfeeding week and newborn weeks. Okay, so this was done in a KMC in a state conference. We look forward again to hold the same events again this year, which will be May 15th, the breastfeeding week, the newborn week. A special thing this year is going to be from 1st to 3rd in December. The Asia Oceania Network of KMC has asked us to hold a physical conference, and we will be holding that one in Ahmedabad from 1st to 3rd December. And we again look forward to the next Kmccon in probably February 2024. And we are happy to support training across India, and you can get in touch with us at our email IDs. Thank you very much, and we'll go to the next step of the program.
As you can see, in our own small way, with our limited resources and enthusiasm, we are trying to take up a few activities to promote kangaroo mother care in our country. And now we are also sharing the same experiences with the neighboring countries also. Every year in KMC Foundation of India invites different professional organizations to come with us, join with us, and make a joint declaration that they will also help in the promotion of kangaroo mother care through their members and their organization. So today I invite a few members here to join us on the podium. Dr. Karishma Narwani, please come here. She is from the Ayurvedic system. For the first time we have invited some person, a leader from the Ayurvedic group also, which we have been thinking for a long time. And now we are also involving homeopathy and other people also. So she is representing that group. Please come over here. Then Dr. Nitish Vora, he is the president of Pediatric Neurology Associations. So this time we are involving them also, because they took a long time to decide whether they can join with us or not. They wanted a lot many evidences, but now they cannot refuse us. So they are joining here today. And then Professor Sushma Nangia, she is our president-elect from National Neonatology Forum. They are the first ones to commit full support for KMC Foundation, and today I request her to come here to renew her endorsement for KMC and take up few more activities now, not just a few things which we are doing, but take up more things. Then I invite Dr. Jena, President of IAP Odisha. Samrendra Mahapatra, he will be representing IAP Odisha. And IAP National President had requested me, because he had a concurrent session today, so he said our Odisha members will represent National IAP. So I am inviting him, please join us. And Dr. Amrita Lenka, is she there? Yeah. Yeah, please come. She is the secretary of SOMI, that is the Society of Midwives of India, and she is also a senior nursing faculty member, and they have also already committed to us, but I am requesting again to reinforce their commitment. So I request all of them, please, I will just read out a few lines. You can go through the rest of the lines because we are racing with the time here. That we, please raise your right hand, all of you please. Raise your right hand. And just, I will read out, and then in the end you will say that we commit or whatever. So, we the professional bodies and other stakeholders of health and development of the people of India endorse the national guidelines for kangaroo mother care and optimal feeding of low birth weight infants, which were initially started in 2014 and subsequent updates released from time to time, and commit ourselves to wholeheartedly support efforts of the central and state governments towards the nationwide scale-up of KMC under the National Health Mission also. Advocate promotion of KMC as a core component of essential newborn care. to educate that KMC is not just holding the baby in direct skin-to-skin contact on mother's chest, but it also includes other equally important components like promotion of breastfeeding, planned early discharge and regular follow-up. To understand that KMC provides several benefits, advocate for universal practice of KMC, and we will make all possible efforts to not to separate the baby from his or her mother, and alternate caretakers also will be given equal importance, and KMC including breast milk feeding should be started as early as possible, and all the other remaining ones, they are all dependent on that. And I request all of you to again, those who have joined us for the first time, they will say yes, we will, and others, we will reinforce the thing. Please say that. Yes. Thank you very much.
We will reinforce.
Thank you very much. This is just to ensure that everybody understands that KMC is not just a poor man's incubator, as still people continue to think, even after our 30 years of propaganda. 30 years, 1993 we started it, 1923 it was endorsed during our, it was taken up in the national policy, and today 2023 we are talking about it. But even today we have a situation, even the doctors are not knowing about it. I am telling you the facts. So we request all of you to make all possible efforts to see that it comes to some level. Thank you very much for joining us. And now I request each one of you to say a few words. We will start with our Ayurvedic colleagues. Please come. As I said, we had been wanting our Ayurvedic colleagues to join us. This is a simple, natural thing where we are just keeping the mother and baby together and promoting breast milk. So there is no conflict of interest. It is a basic, natural thing. We want them to join us. Please.
सबको नमस्कार। मैं डॉक्टर करिश्मा नारवाणी गुजरात जामनगर से गर्भमेशल फाउंडेशन की डायरेक्टर और आयुर्वेद व्यासपीठ जो कि हमारा आयुर्वेद के वैद्यों का संगठन है, उसकी मेरी गुजरात प्रांत के प्रेसिडेंट की जिम्मेदारी है। मैं मैडम को इंश्योर करती हूँ, मैडम ने यही एम से मुझे यहाँ पे बुलाया था कि केएमसी को कैसे मुझे आयुर्वेद फील्ड में ले जाना है। मैं मैडम को यहाँ से एक विश्वास दिलाती हूँ कि गर्भमेशल फाउंडेशन जो गर्भ संस्कार इनफर्टिलिटी पे काम करता है, उसमें वैद्यों की ट्रेनिंग का भी 2 बार प्रोग्राम होता है। ईयर में वो 50 से ज्यादा आयुर्वेद के वैद्यों को ट्रेनिंग करता है गर्भ संस्कार इनफर्टिलिटी के लिए। उसके ट्रेनिंग प्रोग्राम में केएमसी को मैं इन्वॉल्व करूंगी, जरूरी है मेरी, क्योंकि मैं उसकी सीईओ होने के नाते डिसीजन भी मुझे ही लेना है, तो मैं जरूर उस प्रोग्राम में उसको लूंगी। और आयुर्वेद व्यासपीठ जो कि वैद्यों का संगठन है, और उससे सेमिनार और सिंपोजियम बार बार होते रहते हैं। जबकि मैडम वाणी खुद गुजरात में है, तो हमारे लिए वो अवेलेबल वहाँ पे रह सकती हैं, तो मैं चाहूंगी कि उनका भी वो विषय उन सेमिनारों में रखा जाए और ज़्यादा से ज़्यादा वैद्यों को अवेयर हो और ये अपनी प्रैक्टिस में अच्छी तरह से अप्लाई हो सकता है। तो ये भी मैं यहाँ से कहती हूँ कि मैं ज़रूर मैडम का भी उसमें ज़रूर सहयोग लूँगी गुजरात में, कि हम ज़्यादा से ज़्यादा हमारे वैद्यों को पहुँचे और इससे अवेयर करें और इस केएमसी को हम अप्लाई कर पाएँ। मुझे यहाँ आने का जो मौका मिला है, आप सबसे मेरे मिलने का मौका मिला है, और मैं जो मैडम का एंथुजियाज्म इस एज में देख रही हूँ, इससे तो हमें लगता है कि हमें तो ये काम करना ही चाहिए। मैडम अगर इस एज में इतना काम कर रही है से टॉपिक के लिए, तो बहुत जरूरी है कि हमें ये काम करना चाहिए। धन्यवाद वापस आप सबसे मिलने के लिए।
Thank you very much. I forgot to introduce her, but I assure you, she is one of the very accomplished and senior person in the Ayurvedic faculty, and please excuse me for that. Thank you very much. Now Dr. Nitish, just a few minutes.
Sure.
He is the president of Pediatric Associations of Pediatric Neurology Associations. He is representing the different factions also. Please.
Thanks, madam. So, as ma'am say, great efforts by KMC Foundation and respected Mani madam. I represent AOPN, that is Association of Pediatric Neurology, and AOCN, that is Academy of Child Neurology. So on behalf of both of foundation academics, we know there's lots of evidence about the KMC helping with the child's brain development, the neurology network and neuroplasticity. So with both the foundations, all the faculties, all the members of pediatric neurology will try to see what we can do best to endorse and support KMC at every level. Thank you very much, madam.
Thank you very much. And here, Dr. Sushma, we expect a lot from you. And then
Thank you, ma'am, for this opportunity, and as we have pledged in front of you and in front of everybody here, the biggest organization and custodian of newborn in the country, which is the National Neonatology Forum, that pledges its full support for kangaroo mother care. We have so many branches at the state level, certain other city branches, so all these branches will observe the KMC day, and we will be following KMC activities, not just in letter but in spirit. Thank you.
action. Full action. Full action. Thank you. Dr. Lal, please. Without our nursing members, we cannot do anything in newborn care, and we are very important to us. Please.
समस्तଙ୍କୁ ମୋର ନମସ୍କାର। I feel very proud and privileged to stand before you all among all the galaxy of intellectuals, and because I am a mother, and because I am a woman, I am a mother, and I am also the founder of Society of Media of India in Odisha, and so I feel very much proud that we should the aim of Society of Media of India is to provide skilled, safe and affordable care to the mother and save the newborn to reduce the neonatal mortality rate. So that is our main aim, and Society of Media of India has headquarters in Hyderabad, and I think almost everybody will be knowing her. Dr. M. Prakasama, she is founder of Society of Media of India, and it has been established in 2000. So because I am mother, and I feel that I should know that how the baby is important for the mother, and we always feel that in the mother will be always safe in the hand of midwifery. And coincidentally, just I would like to share my experience. And I have worked in nursing in different capacities, from clinical nurse to principal's position, and I always and my specialty is medical surgical nursing. So people say you are med surg, why you are interested in mother and child care. So then I answer them. My specialty is med surg, but first of all I am woman and I am mother, and you know the value of the child in the that is the gift given by God to all of us. So we should know how to take care of the baby. So our main aim is to take care of the mother and child and decrease the maternal mortality, neonatal mortality rate in Odisha and globally. So kangaroo mother care, it is already all so many learned persons are here, and so much they have given knowledge. Here actually I have not come to give knowledge, but I came here to learn something from the galaxy of intellectuals. So I am very much privileged, and I thank the KMC Foundation, NNF and IAP, NHM and all the organizers who have organized this. This is very nice, and I feel very great to be here among you all, and definitely I will always try to involve among the mothers. And I am connected with the associations, that is the grassroots level workers are the ANMs. So the Mamta Nayak, who is the secretary of ANM associations in Odisha. So every year we call her whenever we conduct the conference, state level conference. Every year I conduct one state level conference. we conduct a Safe Motherhood Day, we conduct World Midwives Day, we want World Health Day. So all the health related days we conduct, and of course the breastfeeding, everything. So everywhere where we encourage the mother, and how we will strengthen the midwives, because we want the mothers to remain in the safe hand. And coincidentally, and I have been blessed with one boy and one girl, 2 children, and both the children are proudly, I am saying, conducted by the midwives, and so skillfully, so well they have conducted. So that's why I always encourage, and I would like to strengthen midwives, and so that they should be trained regarding KMC, and almost the ASAs and ANMs are trained how to give KMC in the periphery. So definitely we will achieve our goal by 2030, as Sir has already announced. Thank you, ma'am. Thank you, sir. Thank you very much.
And sorry, I'm hurrying up, but we have to have some time. And now I request IAP representative to tell us that now so far IAP has been endorsed KMC, but had a passive role. From that, let it be a proactive role. Please.
Thanks, madam. On behalf of Central IAP and Odisha State IAP, definitely we will be with KMC Foundation, and we will be actively participating in the KMC. Thank you.
Thank you very much. And now I request Dr. Sumita Ghosh. Please, madam. Sorry, madam.
Vivek. Yeah. Okay. Okay, Vivek.
The last word is for the chief guest, right? Yes.
I request him to release our quarterly newsletter current issue and then give a brief address, please. They are bringing.
That will be the thing.
Yeah.
That we'll do with that.
So good afternoon everyone, and I know it's been long and intense a few days here. So with my greetings to Dr. Vani ma'am, who's been leading us on this very important topic for more decades, and with Dr. Sumita Ghosh ma'am on the dais, who's of course a chief guest, and the last word is always for the chief guest. So I take this honor of representing UNICEF before our chief guest speaks and concludes. But first of all, with greetings to all the people on the dais, but also the organizers, 2 or 3 very important things that I see through this conference, ma'am. One is that we are holding this conference in AIMS. And you know, with the AIMS-like institutions coming up across the country, this is the kind of role we would have envisaged. That's the role these institutions will play in the health system. And for a topic like KMC, it was so good to see from the neurodevelopmental pediatrics, we have our colleague today, because many a times, let us be very frank, not all conditions require medical intervention where you need a therapeutic. We don't need a vaccine or a therapeutic or a diagnostic tool every time. There are certain things that can be done without a therapeutic naturally, and KMC is one of them, which are not very politically viable. So if you call a minister and say, come and inaugurate something on KMC, okay, so he or she might want to know how big is the hospital, where are we going to do this, what ribbon cutting, and if you tell mother has to hold the baby, I don't know, I mean, it was so good to see so many politicians in some of these events. So all accolades to you, ma'am, that attracting politicians to such a thing where you don't have a therapeutic attached to an intervention. But it is such an important intervention, and I think the important point is that we need to keep discussing the science of it. We all know the neurons, how they make connections, and the period for neuroelasticity and all of that. But believe me, when we were having an intense session, and I was not in UNICEF, I was with another agency, and one of my UNICEF colleagues then calls me and says, you know what, today I attended a session on ECD. And throughout and he's a pediatrician, but not in practice in public health for 3 decades. And he says, you know, my eyes opened. And I was like, my God, a pediatrician who may be in public health for three decades is saying, my eyes opened when I learned about what KMC can do. And then I thought, how about people like us who have not had direct specialty training in pediatrics? And there are so many others who are practicing pediatrics, coming in contact day to day, nurses, doctors. So we need to promote this science also, because it's you cannot take it for granted that people know about the value of KMC, and especially for the preterms. So preterms, as we say, this is the natural incubator. Nobody can afford the specialty care, and KMC at least valid for 8 hours to 24 hours. So I think we need to continue talking science. But one thing I would say, which we must add, is science, we all know what it does, but the science of why it succeeds in some place and why it doesn't succeed, why one family is able to do or what is. So I saw a lot of studies outside on one of the organizations, the Community Empowerment Lab. I mean, that's where I see that implementation science is very important, and that is where, when I see the state like Odisha, where Dr. Aditya Mahapatra was telling that 40 people have joined from PIP. So this is the kind of future we want to say, if we want to inbuild this in all home-based care, facility-based care and other modules. Dr. Ghosh ma'am was very rightly saying, we cannot take out and make KMC standalone. We need championship by people like Vani ma'am, because it takes cultural ma'am who have stood the test of time, 30 years, 40 years. But we cannot make it standalone. It has to be integrated in every package which is about newborns, and especially those with low birth weight and preterm. I think that's a very important point. And we must keep looking for answers of implementation science, that if it succeeds in one district in UP, vis-a-vis not succeeding in many other districts in UP, what is it that that district is doing differently? Is it something about the health workers? It is something about the behavior change communication, the way we are engaging with the communities. It is something about, else about the health system. So I think this implementation questions also, we must continue finding answers to, and I think government is also increasing resources, the trainings on implementation science. Last but not the least, I just want to remind all of us that some of the updates that have come on small and sick newborn care, and that's why, being a rights-based agency as UNICEF, what we like the most is that when we say every child has a right, and if you go by definition of a child in the Convention of the Rights of the Child, it's from the birth to 18 years, right? Now, how about the rights of those children who cannot speak? A baby who's born today. So this is when the update says that we need to respect and protect and fulfill the rights of every newborn and provide dignity. That with KMC, the neuro axis that gets generated, the child will have a better sleep, will have better bonding, will be less stressed, and we know all the what stress can do through our hormonal axes, right? So when we know a child who cannot speak also has rights, and the science tells us that if we provide KMC or we do not provide KMC, what's the difference? So I think this is a very important point, that we also have respect to protect and fulfill for these kids and provide care with dignity. Another point, which is my last, I want to pick from when these guidelines were released. Many of our Indian scientists are also part of it always, so which is very heartening to know, and especially I saw Dr. Shushma ma'am's name also on that list and others, that parents from 203 countries across the world, low, high, middle income, said that when it comes to the care of a newborn, and especially if the newborn is at risk preterm, parents want three things. Of course, no brainer, they want positive outcomes for their babies. But two other things. Parents want to take active role in deciding the interventions for their baby because they're curious. Our baby is special. We want the baby to have the best outcome. So how can we play an active role in the management? So we cannot keep parents outside the nursery and just let them wait till the baby is stable enough to leave. And the third point parents want is involvement in delivery of the care. And I think that is where also, apart from respect, protection and fulfillment for these children, providing developmentally support care to the families and newborns, and providing emotional and psychosocial and development support to family as a unit for these kids. I think these are very important points, and as we move forward in all our trainings, we must make sure that gradually these things also get into our trainings, and our trainings are quite well funded through the PIPs now. And we were just discussing how states have started becoming ingenious and also claiming funds for such activities. So with that, all congratulations to the Odisha government also for supporting KMC Foundation for hosting it. And ma'am, to you, especially Vani ma'am, that 30 years of championship for this, and 40 years when she just told me that NNF introduced the home-based care model in India. It was in 1982, or so now 40 years. And India has actually handed over packages of newborn care to WHO, who's the normative lead globally for developing many of these packages, not of course claiming entirely to India, but very significant contributions, and I really congratulate KMC Foundation for that. Thank you very much.
First of all, I want to say it is the teamwork which matters here. I would just like to introduce, means they are all well known in their own figure, but for KMC Foundation, all our members who are there, and also thank all the members who are not here. Dr. Kharod, Dr. Somsekhar, Dr. Parag Dagli, Dr. Deepa, please come over. Few people are here, please give them a big applause. They have been all toiling a lot. And then we have many others who could not stay for a long time, they have left. And there are a few others who are holding the front bag so that others can come over here. And there are many others. Thank you very much for each one of them. Thank you. Now I request Dr. Sumita, please. She has also now become one of our family members.
Thank you, ma'am. I have been attending this and I'm part of it, I think since 2021. Every conference I'm there, whether physical or online. Thank you, ma'am. I am very happy to be part of this family, this KMC Foundation, which has single-minded devotion, focus, energy. You and ma'am Shivani and the team, they are focused on it every year, annual conference, and bringing to that focus which has come through all this work, and ministries, of course, it has taken up from the initial beginning. 2014 ministry also has taken up this in a big way. So I would say today's oration, when I was listening, that so near yet so far, I would like to say to this August gathering, because everyone expects data from government, so I will touch that point. It is not that far anymore. We have gone a long way from where we started. Our SNSU concept has changed into MNSU concept. 117 of them they are now approved, and every PIP, so many supports are being given. Talking about babies who are getting KMC, last year data, if we see, below 2000 gram babies in our SNSUs, because we have a very robust data system in SNSU online. To say the figures, 3.05 lakhs were below 2000 grams, and 90% of them received KMC in some form or other. That is a big jump, kangaroo jump, I would say, from where we started. Yes, concerns are there, how much they are getting, when they are getting. So those things, of course, are concerned. But it has, because all of our efforts, all those who are here, all the champions, the state governments, the central government, and all the federations, NNF, IAP, others who are actually made it happen, that it is now in the consciousness of all those who are taking care, and things are improving and things have gone to a certain point, at least in the facilities. The nursing staff, the other staff, our counselors, our doctors, they are more or less sensitized to this because of all the effort. But things are remaining, how that continuum, as it is being discussed in so much words, so many words it has been discussed, how community and the continuum of care is there, how immediate KMC can be promoted, that anxiety in health worker providers in very small babies, that it might not be feasible, so that how that anxiety can be laid, how much we can give, how we can improve the contact, skin to skin contact time, how frequently, how long, all these concerns are there still now. So this conference, so many words it has been explained, that the benefits, the added points to this very vulnerable, fragile babies, so that we will take up, and also that it is a process. Our NHM support is a process. When the states understand, when the states ask for it, demands for it, prioritize it, then of course we are no one to say no. We always say yes. We promote the KMC guideline 2014. Maybe we'll have a relook. In all our training programs, as Dr. Vivek has said, as a package, it is being promoted all through. And in our Kmccon, quality certification, again, it has become a very pivotal point in the KPIs which are to be achieved, to achieve that benchmark, as well as in our NQAS, KMC was already there. So again, it has been highlighted. The PMJY packages have come for KMC. So all those who are outside the government sector, they can get that benefit where they are treating that benefit can be there. Even our SNCU and all, they can promote it further. Another thing I want to say, and that it is always high on the agenda, because newborn mortality survival is still the point which we are, many states are grappling with. So newborn, premature newborn especially, which constitutes some 46% low birth weight and premature, which the SRS report, latest report says. So this is one area where we can gain a lot with the promotion. And of course, our ECD promotion, early childhood development, which is beyond survival. Again, KMC adds lot of advantages, lot of benefits to it. So this is one area. Again, we are promoting through our IECs, through our ECD, that app which has been developed, posters and all. You see, breastfeeding and kangaroo mother care, both are on the prime on the agenda. The latest thing which I can say from the ministry, that there was a chief secretary conference where a lot of discussions on RMNCHA as a whole, PM, maternal and neonatal, newborn health, child health, with a special focus on that. There again, it has come out that PNC, postnatal care, is the very, very prime area, because women are not staying in the institute after delivery long enough. So we are trying to promote that, and in that period, we want to utilize that 48 hours with lot of capacity building, lot of training to the parents, mothers, so that they can, take take the reins and they can go forward. And in our HBNC visits also it is there, and we will try to promote it more, which I think 4 things which will take this movement forward. It should be a Jan Bhagdari kind of movement where everyone should be a part of it. That is, first thing is awareness about it, awareness about the good things it can bring in the child, the most motivating thing for a mother. Then counseling part again, Sushma said that counts, and also it came out that counselors play a big role, and we have to train them for counseling for breastfeeding as well as including KMC. Third thing is the capacity. We are doing through all our newborn care packages, all our training programs, it is a part, and now it's so heartening to see that even Ayurveda, Ayurveda system has been roped in. It is again a big change. It will come because in-service training is the time to orient and motivate doctors, nurses. Also, there again it is a big scope. Our CHOs, community health officers, who have come up in 1.54 lakhs of health and wellness centers. We are planning a package of training for them in neonatal and child health. Again, we want to promote KMC because they can have a very big role in promoting it in the community. So in various platforms, in our ANC counseling, in our postnatal, everywhere government is trying and will try more so that all the babies who need KMC, they get it because it is their right, as was proclaimed in way back in 1998, I think Bogota said it is their right. Thank you very much for bringing me here and adding the force to KMC. Thank you.
I request Dr. Parag to give the vote of thanks for Dr. Sanghamitra.
So I'll be as short as possible, and the last obstacle between you and your lunch. So good afternoon to one and all, to all distinguished guests on the dais, off the dais, the esteemed faculties, parents who are here, ladies and gentlemen. It's indeed a pleasure to express a vote of thanks on behalf of KMC Foundation India to all the individuals and organizations who have made this event happen. On behalf of KMC, I would like to specially thank Dr. Sunita Ghosh, Additional Commissioner from Ministry of Health and Family Welfare, Dr. Vivek Virendra Singh from UNICEF, all the authorities of NHM Odisha and AIMS Bhubaneswar, individual organizations and their representatives for contributing to joint statement of KMC promotion, namely Dr. Karishma Nagwani, Dr. Nitish Vora, Dr. Sushma Nangia, Dr. N. Jaina, and Srimati Amrita Lenka. I especially thank the organizing team of IAP and NNF Odisha. Few of the names: Dr. Aditya Mohapatra, Dr. Mishra, Dr. Sahu, Dr. Ajit, Dr. Khan, and several others whom I cannot name. But you people have made this event happen, and the organization has been excellent. The venues, the food, and your overall approach. Thank you all. I would also like to thank all the eminent speakers, the national as well as international ones, who have taken time and pain to share their knowledge with all of us. I'd also like to thank all the audience who are here and all those who are online. And last but not the least, Dr. Shashi Vani, who has been a driving force for all of us. Honestly, ma'am. And thank you all again.
One more person I have forgotten. Dr. Vishwajit for a very nice oration, and our own family member, Mr. Prakash. Please give him a big hand. He has come without expecting anything, just to join us all the way from Ahmedabad by train at very short notice. We have several other members, but they could not come here, but at least this time he has come. Thank you very much. One and all, whomsoever we would have forgotten.
Dr. Samrendra.
Yeah.
Dr. Samrendra, please, for a vote of thanks.
Good afternoon all. First of all, welcome to AIIMS Bhubaneswar. Distinguished guests on the dais and off the dais. We are grateful to KMC Foundation, particularly to Dr. Shashi Vani. She trusted Orissa, NNF, Orissa, IAP, NHM can do this 7th national conference. Yes, we have done it with the help of UNICEF, NIPI and Indian Oil. And on behalf of my organization, particularly AIIMS, I am grateful to our director, Professor Ashutosh Biswas, our MS and our dean. And also I am thankful to the IT team of AIIMS Bhubaneswar and engineering team. And we are grateful to UNICEF, particularly to Dr. Vivek, Meena Madam and her team. And also we are thankful to the international faculties like Professor Douglas and Dr. Richard. And also we are thankful to the national faculties and local faculties. And thankful to everybody, particularly the delegates. Thank you.
Thank you, sir. Thank you, doctor. Now I request Dr. Sambhavitra Mandana to please come up on the stage and honor the dignitaries on the stage. Thank you, ma'am. Dr. Sambhavitra Mandana is the President of NNF Odisha.
Faculty. Yes, sir. Yes, sir. There.
Dr. Vishwajit Kumar, please come up on the stage.
Thank you.
We
Thank
have a
you.
huge round of applause for everyone on the stage.
Please join, please. Big round of applause, please. Big round of applause. Now we'll break for lunch, and after that we have got 2 sessions in the afternoon, and few announcements. Madam, please. Few announcements for the participants. One is please sign in your attendance sheet, because you have been you are all relieved from the government service for 3 days. So up to 22nd you have to sign in the attendance sheet. Second one, certificates are available on the outside registration counter. You can go there and you tell your name so that they can write the certificates.
And the cash prizes for the posters and oral papers will be given after lunch, so be here at that point of time, or ask them to come over here at that point.
And lunch is for 20 minutes.
guest lecturers, I would like to request Dr. Aarti Behera, Professor and HOD, Sri Jagannath Medical College, Puri; Dr. Somsekar Nimbalkar, Sir, Honorable Secretary, KMC Foundation, India; and Dr. Pankaj Mohanty, Associate Professor of Neonatology, AIMS, Bhubaneswar.
Given your slides?
Yeah, she loaded them.
Dr.
Nalind? Yeah, I'm going to do the first one, the quality improvement.
Nalini Singhal ma'am to speak on the need for quality improvement in KMC.
दूसरा वाला neonatal वाला.
Dr. Nalini Singhal is a professor of pediatrics neonatology at the University of Calgary, Canada. She is currently a member of the KMC Working Group for the World Health Organization, a member of American Academy of Pediatrics Steering Committee for Helping Babies Survive, and a member of the Canadian Neonatal Network governing board. Dr. Singhal has spent the last 25 years helping to develop and implement simple programs like Essential Newborn Care for WHO and American Association of Pediatrics to help save newborn lives. Her interest has been in quality improvement, and she has helped to develop and implement programs for healthcare providers in Canada to improve the neonatal outcomes. I would like ma'am to start the session.
Thank you. It's going to be hard to keep everybody awake, but I'm going to try my best. This is what I'm going to talk about a little bit. I think it's time for us to be starting to transform neonatal care, how quality improvement can help with that, and a little bit about integration of QI and KMC, and then the data that we need for QI. This is a concept from the past. This was the Chicago Fair in 1933. When, if you look at this picture, this is what they were doing to show babies in incubators. If you look at the one below that, this is what we do today, and then we say, well, we don't have isolates, well, we should do KMC because we don't have isolates. No. That's what we need to do. It's time for us to admit that the mother is the care provider, and us as healthcare providers are going to help her take care of the baby. If you look at the evolution of neonatal care, ventilation only started in 1970. And then we started doing some randomized studies in steroids, surfactant, ECMO. And if you transpose quality improvement on it, it was only in 2010 that we started to think about quality improvement as an integral part of neonatal care. If you look at the outcomes, this is clinical care, and we can always improve it. How do we shorten the time? We shorten it by doing quality improvement, so that the neonatal care that would take us years to improve can improve very quickly if we do it with quality improvement. If you look at us in Canada, we compared ourselves to the developed world, and that red line is Canada. And if we look at mortality and morbidity, giving some points, we were one of the worst amongst the countries in the world, developed countries in the world. Once we started our process of quality improvement, now as you can see in the red line down here, we're one of the best. And places like Australia and New Zealand, they're all saying, Sweden, which is now started changing the other way, they were getting worse, are saying What are you guys doing? And all we're doing is teamwork with quality improvement. So if you look at change, how do we change? Most of us are used to it, and somebody, as old as I am is going to say, well, I've done this for 100 years. Why can't I keep doing it? Well, no, I can't keep doing it. And so what we need to do is, as a team, we need to see what we can change. And we need to get our team to generate the ideas and decide what are good change ideas, not me. I'm not the one at the bedside at 4 in the morning every day, but there is somebody there, and that person will have ideas on how you can improve. So what we did was, we involved all our teams, the nurses, the the other healthcare providers, and we decided that we would look at early changes. That was simple and easy to implement. Then we went a little further. We did changes over a wide variety of conditions. Then we went further again, and it took us a long time, and we're still doing it. And the reason for that is we recognize that quality improvement is an ongoing process, not something you do for a day. So now let's look at KMC. Can we do the same model? Yes. And we do it every day in our lives. If I want to go out and get food, I make a list. I go to the market, I look at what's good, and then I return home. Well, in babies, what we should be doing is finding out which babies are cold, then we can measure the admission temperature. Sometimes we can warm the birthing room, sometimes it's skin to skin, and we can look at transportation skin to skin. But it's not a decision that individual can make where you're going to fall on the whole spectrum. If you look at the science of implementation and change, the utopic is that you know the medical science, you have the education programs, and you do local implementation. This comes from the adult literature for saving cardiac arrest patients. And then the survival is there. Ideal is 100, 100, 100. That's not going to happen. So where are we with KMC? We know the science. At least 80% of it we know. We're not doing the education as efficiently as we could. So we should try and improve the educational efficiency. But what we're not really doing is listening to the local people in how they're going to do it. If I do it in one way in Canada, or if I do it in one way at All India Medical Institute in Delhi, is that the best way to do it? No. The local people may have local ideas, and that's what we need to do for quality improvement. So the EPIC-based, evidence-based practice for quality improvement on which our outcomes were based was started in 2002, and 20 years later, we're still doing it. And what we do is we promote dialogue between the teams, and then we share our best practices. Nobody does everything well, and we all know that. I mean, even if you're cooking, I might know how to cook one dish, you might know how to cook another dish better than me, and third person knows something else better than the other two, and you have to learn from each other if you want to produce 3 perfect dishes. But we don't do that. Why don't we do it in medicine? So that's the concept of quality improvement, of sharing our best practices. We do have to evaluate, and we do need data for sharing the practices and the interventions. So we always have a reason. Well, I can't do it because this is happening. Well, I can't do it because this is happening. Well, if you study a problem too long and have too much data, that's going to cause problems. So it's our responsibility as healthcare providers to simplify it and collect just enough data. We do need to start with a small group, as I said, the early adopters. You have to look at what you can change without changing big structures. And I'll show you the example of Dr. McMillan's talk on what we did in Uganda in that. And then you've got to focus on the small things that you can, low-hanging fruit first, And then you've got to get your senior leaders on your side. Administration has to buy into it. And as physicians, we're not very good with that because we normally just deal with one patient and we're great with that. And we think administration doesn't know what we're doing. It doesn't matter. They've got to be on site, whether they know or not. And by having that, then you can get change. So what we did was, we decided that, we've normally had education materials here. We're going to teach resuscitation. Then we're going to have a team that's going to teach quality improvement. And then we're going to have a third team. Well, we thought that if we're going to do it, quality improvement and KMC had to be integrated in a simplified manner, and so that you could do the preparation, provide the learning, help the family with learning, and follow-up and assessments. So this is the conceptual model that we follow, where you have input with data, you have processes that you analyze, and the output is the implementation and the audit. And that needs to be set up anywhere, whether it's a healthcare facility, whether it's a community practice, whether it's AIMS as we're sitting in, it doesn't really matter. And the other thing that we forget is the center has to be the mother and the baby and the individuals that provide the care. We forget that. We sort of seem to focus on the organization. And then so you need to focus on the organization, but please don't forget the individuals. So our possible solution for data collection was, it's in Uganda, they designed it, which is very simple. It's called PRISMS, and it provides ability to collect simple data, and they have shown with that they have been able to change practices, especially with not having babies cold. And finally, I'm going to leave you with the thought that you need a network. So the network can be different KMC centers that provide data, that provide the benchmarking, that will help you do the quality improvement processes, and you'll feel good about having done the quality improvement because you'll make the changes. Paul Battledon was a healthcare provider, and he said long time ago, making improvement happen requires the unshakable belief that everyone has two jobs when they come to work: to do their work and to improve it. And our third job that I've added is to share as active members of newborn community with what we're doing so that we can get others to improve. And Mark Twain told us that the secret of getting ahead is getting started. The secret of getting started is breaking your complex, overwhelming tasks into small, manageable tasks, and then getting started on the first task. And we seem to always want the whole, it's not that you don't keep the whole picture in mind, but we've got to start somewhere small that's manageable and that'll give us results. And then the last quote I'm going to leave you with is from one of my favorite people, Mother Teresa, who said, "You can do what I cannot do, I can do what you cannot do. But together we can do great things." And that really is what quality improvement and teamwork is about. Thank you very much. Because Dr. McMillan was sick, you're stuck with me hearing what he was going to say about Uganda, and we apologize for that, but I'm just going to change the slides to his slides. Oh, did you want questions, or?
It's quite happy to have you, Madam Chair, and it's a quite a brainstorming lecture. Especially you know the success comes from many states, and the roadblocks has to be individualized and solution has to be found. So it is quite wonderful talk, and this is optimal questions. If any questions is there, and we'll ask them.
Yeah, okay. That's it.
Any questions questions are there from the audience, please. Madam, university also conducting some of the courses for echo and ultrasound from the University of Calgary. So we are also being benefited by this.
Yes.
Yes.
Yeah,
So-
Majida is here somewhere. There she is. She conducts the shops on echo and ultrasound. Yeah.
So we are also taking part, our students also taking part faculty as well.
Yeah.
So we are being greatly benefited by your kind of thing.
Thank you.
Thank you. So if there is no questions, then we will call the session.
Okay. All right. So I'm giving this on behalf of Dr. Doug McMillan, who could not be here due to health reasons. And what I'm going to talk about is the need for implementation of KMC and what we did in Uganda. The worry all of us have had is that KMC was first reported 40 years ago, and for the last 20-25 years we know that it works, and yet the coverage in the world is 5%. Guidelines are available, but simple education programs integrated with QI are not available. And it's the same slide that you saw that I had in mind, which is the integration of QI into KMC. The idea of developing this education program was that it should be interactive, using familiar education methods. So we use the education methods of helping babies survive that we've shown have been very helpful, which is simple pictorial and not really based on slides where we then tend to talk more, but more teamwork and sitting on a table, and we're going to do the workshops in the next 2 days. The focus of these is that the healthcare workers are assisting the mothers, which is what I showed you, that forget about incubators. It's the mothers that have to provide the care and the other family members. So that is the focus of the education program. And we want to provide people with some tools to overcome barriers when we're doing it. And the other thing we were worried about is that workshops are quite expensive. So we wanted to limit the cost of education to help sustainability by training people that can train others in the area so that you don't need anybody to come to really train. And the last thing was we wanted the program available free of cost. And we've had some success in it, and I'll tell you how, if you want to, you can download the materials. So we first developed the flip chart model, which was the Helping Babies Survive model. Then we did include a readiness assessment, because wherever you're doing KMC, the place has to be ready for it. You know, if the mother doesn't have a bed, she has no food, it's not going to work, kind of. It does have knowledge assessment. I had input from 13 selected global experts, and we did the testing in Uganda, Tanzania, and Nepal virtually because EPIC had, COVID had come along, so we couldn't do it personally. And the evidence-based practice improving quality has been a Canadian program that has had multiple testing over the last 20 years. And then we made all the modification, and there was a small grant for it. So this is what a flip chart page looks like. And I know it's busy, but I wanted to show you the overall design of it. And you start by asking, then you demonstrate, and then you indicate the importance, and then you invite further discussion. And if there is a need, you can show videos, and then there's some additional advice in the background. That's the design of the page. The exercises in it are designed like this, that you've got very directive activity for the exercise. You give this scenario, and then you use a checklist to see how the person is doing. But what you're doing is you're teaching people how to do it. You're not really testing them. What we found is that the knowledge scores of 33 nurses and physicians increased by 79 to 88%. The learning process indicated as 77% of the participants said it was very useful. The negative comments were, I prefer physical training to virtual training, which is now possible. And the other was, we were doing it because we were doing it online at different time zones, sort of after work hours, and people didn't like that. The positive comments were it was very supportive. I liked the link between EPIC and KMC. EPIC is the Quality Improvement Program, and it'll be self-sustaining, and they're actually expanding it in Uganda and Tanzania. So it is a self-sustaining program that is expanding, and now we're looking at sharing it with you people in India. It will be posted on the International Pediatric Association website for download for free, and it's posted on the Canadian Neonatal Foundation, who owns the rights to the Quality Improvement Program. So what did we do in Uganda? In Uganda, what we did was we had a Rotary partnership. We bought them a little bit of equipment. We taught them how to sew the KMC wraps. We did the training. And they then made what they called it the KMC cave. That's what they wanted to call it. They on their own decided how they were going to get volunteers to cook for the mothers, so the mothers had food, and the activities started in January of 2021. This is what their cave looks like. So it isn't, the African women are much more comfortable breastfeeding in public than we would have in India, and they were all very comfortable in this cave. This showed in 1 year that the KMC increased obviously from 0% to 65% because they now had a cave to put the babies on. But the important thing they found is that there's survival. Only 2 babies died out of 363 in the KMC period, and before the KMC period, they were having 30 to 50 babies die, which is a huge improvement in mortality. They had better weight gain. Babies then came back for follow-up, and there was improved community awareness. But then what happened is Uganda has this results-based financing, which means somebody from the government comes around to assess what you're doing, and then they pick a few places that can get more money. Because of the KMC program, they were able to get more money, so they could increase the KMC cave size from 4 beds now to 10 beds. So they were just delighted that they've got more money to do 4 to 8 beds, sorry. And they had a lot of parents teaching parents. So once the nurses initially the nurses were worried that their workload was going to increase. They found that the workload significantly went down because the parents took over a lot of the teaching once they started teaching the parents with this flip chart. This is a teenage girl who decided because his mother was really sick, he was going to provide KMC to his brother so his brother could survive because the mom had PIH and couldn't do it for 2 weeks. And we also had fathers involved in the KMC. The staff then reported increased job satisfaction, and they found small quality improvement projects to do. They made sure more babies were normal cervix on admission with the QI process, and they found that they could triage the babies better, and their relationship with parents increased, and workload did not increase. So the staff was very happy. So in conclusion, what we did in Uganda and found that is QI is efficient and effective. It improved knowledge and skills, and the providers helped in monitoring and implementation. Integration with quality improvement was key, and it was helpful in program implementation, and they're sustaining it now. The Rotary grant is over, but they're doing it all on their own now. And the Rotary grant, as I told you, was not a huge amount of money. It was just getting them started. The focus now remains the mothers and the families, not the healthcare providers. And it established a benefit for the families, for the healthcare providers, and for everybody else in the community. We need some further studies for implementation guidelines, as I didn't catch the name, as the physician from UNICEF was saying. And this is the time to be looking at collecting data for implementation. But we have to remember the implementation is not research the way we've been used to doing it. It's simple, straightforward. You may or may not believe it, but that's what that area needs, and those are the kind of studies we need to do. So thanks for, this is Dr. McMillan writing it, thank you for the opportunity to contribute to better care and outcome for small babies and their families. Thank you. I don't think I can give his talk as well as he can, but I tried. The barriers they had initially was they didn't have food for the mothers. And the other barrier to them was that the families didn't have a place to stay. So the head of the Department of Pediatrics got some people to donate. Sorry. The head of the Department of Pediatrics got some money and just outside the hospital built a shack where the families could stay at night. And the volunteers cooked and the Rotary gave the money to buy the groceries. So they put it together. That was one big barrier. The second barrier to begin with was the nursing staff that thought that their workload was going to increase. And they were, so we really had to, we went along with the head nurse and we got her trained and we got her to help training. And the other advantage we had with the Rotary grant is we had we could employ one person to help out to begin with, to collect data and stuff. That's all gone now, and they're doing it on their own. So those were some of the big barriers that we faced to begin with.
Do they think this is replicable in other places?
Yes, they do. And the government of Uganda is looking at rolling it out in 5 districts. Because they always say that UNICEF comes, USAID comes, then they come with big money, then they leave and we can't do it. You guys didn't come with big money. You guys just came with an education program to try and get people involved. So that's the reason that they believe that they can sustain it and replicate it.
Now, in some places they have the experience that even if you provide the services, because of their other needs in the family, mothers are not able to stay in this designated places.
Yeah. And I think that's going to happen. I think if we think that 100% of our mothers and families will be able to stay, it's unlikely. But I think if we can even get to 70, 80%, it's better than where we're at now, which is, in the world, it's 5%. Like the mother that was sick with PIH and seizures, I mean, that family would have said no. But because they had bought into the concept, her eldest son said, I'm going to do it. And we may be surprised that how many families then will find somebody to do it.
I'm just expressing the concern.
Yeah, that's going to be there.
I want to expand it.
Yeah. Yes.
Thank you, ma'am. And Susan, for your encouraging messages. And like other developing countries, we should adapt and plan the roadmap consisting of simple steps which we can we should not provide only to the healthcare provider. Also, we should involve the family members and all other volunteers to adopt it and make to give the quality care to the newborns, and we should follow that also. Thank you so much.
I just want to make one comment following that. This has nothing to do with developing countries. Please stop saying that, okay? This is what the baby needs, this is what the mother needs, this is what the family needs. Doesn't matter where you are in the world, doesn't matter if you own a gold mine or if you don't own a gold mine. That's what you need. And That's why I keep saying, let's not sell the baby short. Let's not sell the developing countries. This is what we need to make happen for every baby everywhere in the world. Thank you.
Thank you so much.
Thank you, ma'am. That was a very insightful session. It was indeed a privilege to listen to you. Now, I would like Dr. Aarti ma'am to felicitate Dr. Nalini madam. And also I would request Dr. Nalini ma'am to felicitate Dr. Aarti ma'am and Dr. Pankaj sir.
Thank you, ma'am. She's going to be around for almost a month now.
Yes, I'm going to be in India for a month.
Thank you. Before we go to the next session, I have an announcement to make, rather money to distribute. So prizes for the oral poster and oral and poster competitions that were held yesterday. So I would like to announce the first prize for oral in nurses category to Hepsi Y. Joseph, if she's around. So if someone else can be trusted with the money, they can come forward and take the prize on her behalf. She's here. Okay, great. So there's a cash prize of 2,500 rupees for the first poster. The title of the paper was Experiences and Pursued Barriers Towards KMC Among Mothers of Preterms in NICU. Congratulations. I would invite Dr. Parag to come over and please hand over the cash prize. I would request Dr. Deepa to come on the stage also. The next prize is The next prize is for the first prize for the poster from the nursing category is Dr. Nurse Somi Karmakar. Is she around? Yeah, good. I request Dr. Deepa ma'am to hand over the cash prize. Her title of the paper was Effect of KMC on Breast Milk Expressed in Low Birth Infants in a Tertiary Care Hospital in Eastern India. Congratulations. I would request Dr. Sushma Malik to come on stage for the prize for posters in the doctors category. The prize goes to, because this was the most hotly contested category and there were a lot of people in this category. So the first prize goes to the title Smartphone Based Applications for KMC, Dr. Gaurav Gautam from HGBJ Lucknow. He is not there. Jagannath. Okay, so there was no prize for the doctors category, oral category, because that was the decision of the judges, and with that I will conclude the prize distribution.
There's no prize for the
oral category. Marks नहीं मिले. Marks नहीं मिले.
Marks नहीं मिले.
हाँ? There was only one person and the presentation was not good, considered good enough.
Okay.
Okay, thank you, ma'am. Sorry, ma'am. I think we can hand over to the next session.
Thank you very much, sir. Congratulations to all the winners. Huge round of applause to all the winners, sir. Now we shall begin with the next session. which is the open house, practical aspects of KMC and way forward in Odisha. I would request Dr. Professor Shashi and Mani ma'am to please come up on the stage. Now I will request the panel members, Dr. Professor Leena Das, Professor and HOD of Department of Pediatrics, PG IHAT and Capital Hospital, Bhubaneswar, Dr. Professor Sambhavendra Panna ma'am, the President of MNF Odisha, Dr. Aditya Mahapatra, Senior Consultant Pediatrics, NHS Odisha, and Dr. Rajesh Marka, Health Officer, UNICEF Odisha. I would request the doctors to please come up on the stage and grace us with their presence. Thank you.
Samit, hold its quarters. Sir, Mike. Mike, sir, एक पे sir, एक पे लाइट
Very good afternoon. Thank you very much for this opportunity, and this presentation is on the already existing. We have the kangaroo mother care centers, KMC centers in most of the SNCUs. So we are, in my presentation, I am trying to highlight some of the areas where we can improve, or which are the opportunities for us in Odisha, where we can improve the quantity and quality of the KMC care. So these are based on some of the anecdotal evidences what we collect during the visits, and also some of the evidences which come out through our HBNC visits. So there are certain areas which I think are quite important, which requires some kind of monitoring and improvement. One comes to the identification of the premature and low birth babies. What we identified is, you saw in some of the presentation earlier also, there's some peaking of the weighing of the babies in certain categories, because the recording is not happening properly, and also non-availability of the weighing scales in most of the labor rooms, especially the electronic and calibrated weighing scales. Then comes the history taking of the EDD during the VHND, because in Odisha is a state where most of the ANC cares, first ANC happens in the VHND, that is in the Anganwadis, village and the nutrition days. So those are the areas where if they don't take the proper history, then the chances of that they might miss the gestation date. Then the examination of the women or the pregnant woman during the VHND, that is also not being done as required, and most of the times it is because of the space constraints because of the people they are catering to. A lot of the issues are there. This is an area we can focus on in the coming days. And the tracking the maternal weight during ANC. This is also an area which we are finding that though they have the stadiometer and the weighing scale, it is not done completely, especially because of the ANC, quality of the ANC. So these are the area. Then the availability of the ultrasonogram during the ANCs. Though we expect that all the PMSMA sessions should have this ultrasonogram done, but it is not done in all the places. Maybe the unavailability and lack of the setups, especially in some of the rural southern districts, we don't have even the private setup also to support this. So these are the areas where we tend to miss out, or the way to identify the low birth weight baby sometimes. That's what we are concerned is. The second is the facility-based KMC. Most of the things have been told already. I'll just highlight this because of the knowledge and attitude and practices of the health worker is quite important in this. The main point here is the time provided by the staff. There are certain places, the two staff nurses manages whole CSC. That is quite difficult to manage, in fact. Seeing the patient, seeing the OPD, emergencies, everything. So that is the area which it is a larger debate where we should increase or we should try to get more staff nurses to these positions. Then the counseling skills. They know that they have the knowledge, but the ability to counsel, I think that is another area which we can think of how we can improve that. Data recording and monitoring at the facility, which I will come later, because there are certain KMC registers are there in the SNCUs, but it's not in all the places. Then coming to the community level KMC, which is actually we are very much interested to take it forward. The knowledge of ASHAs are quite important in this. So this time we have able to get the booklet of on KMC in Odia language. Maybe that might help us, the ASHA, to learn or at least get taught on the KMC aspects. And this can be in fact told in the sector level meetings so that they know about it, because the ASHAs are the one who does the home visits. Then the LBW babies are such that unless they prioritize the visits, they can't reach everybody. So there should be a system, already it is existing, I will come to that in the next slide, so which can prioritize the babies who are of low birth weight or discharged from SNCU, such kind of babies. Then the follow-up mechanisms which is existing for the SNCU discharged babies, but there is none for all the LBW babies. So that also we have to take up. Then supervisory staffs. The supervisory staffs, especially to the ASHA level or at the local level, are they may not be aware of all the aspects of the KMC. So mostly they are not from the medical background, and they do so many visits. They do so many visits, and these are the staffs. I think the capacity of these staffs has to be built on the importance, of course, and the how to do the monitoring of KMC. Then the ASHA kits. This is the area which is again issue, whether every ASHA has the weighing scale or maybe the tape to see the head circumference, all other things. Then growth monitoring charts. Coming to the how to continue the contact, because if we identify the babies who are low birth weight, what are the mechanisms we have to identify or continue the contact? One I suggest means we are already working on this. Anmol is actually interface of the RCH portal at the field level, where they enter about the ANC care to the child's immunization. There one component of that missing is about the facility-based delivery details. If the mothers are continued registered early, then they can be actually monitored to the outcome of the deliveries and later to the HbA1c. So that tools, because the live listing can help a lot when we have when we register it early. So that Anmol is the, or we can say RCH entry is the one area we can focus on, so that we can track the all the babies throughout their life cycle. Then the HbA1c visits is already talked about, especially the quality of HbA1c visits, and able to prioritize the babies who are actually low birth weight. And one more things which the HbA1c can do is to create an peer groups among the mothers who are, and they can also educate the mothers who are supposed to be the KMC. Then the BHNDRI sessions, which are again the point of contact right from the ANC. We know that a lot of mothers who come to ANCs ultimately deliver to a low birth weight baby, because we have around 26% of the mothers delivering. So that could be an area to prime them when they come to the ANC, so that they are well aware of the ANC, KMC care. And so once they deliver a baby, could it be the universal KMC also, so they can provide KMC at the right time. Then comes the HMIS. HMIS, as you know, Health Information Management System, is the one which captures the aggregate data of all the services being provided by the government. And that could be a very good tool to identify some of the sub-centers which has a high level of low birth weight babies. So these babies or these sub-centers could be focused, so that the whatever ways we can create a peer group, we can create this Sri Shakti Sanghas, we call it Mission Shakti here. So these can be used to create a advocacy or also the training platform to the mothers who are on this place. Then coming to the intervention we started in Koraput and Malkanagiri is the labor room tracking. Of course, we heard that with ma'am that the postnatal ward is the best place we can prime them. Later, what is the mechanism to track them? Do we have a mechanism? We tried in some of the 2 districts where the register is kept at the labor room, and the staff nurse of the labor room tries to contact to all the babies who are born low birth weight. This is quite effective mechanisms. We have prepared a paper out of it. Of course, I should thank Dr. Aditya Mahapatra for starting this. So that has been quite wonderful, successful. So these are the different mechanisms, so that we will not miss the children or the babies who are born low birth weight. That's all my presentation. Thank you.
Thank you, Dr. Brothers. On this occasion, I want to invite another senior pediatricians of District Headquarters Hospital and in the Chandrapur and Kapula Goda sir is there. Please come to the dais. And
I would like to come closer and talk rather than now. Some of the very practical, important issues have been raised. At least in our context, I would like to start with 1 or 2 important ones. First and foremost is weighing of the baby. Even in our, I'll start with the facilities first, then go to the community. Even in the facilities also, sometimes the weighing is not done. So that is one thing we have to take up. Now most of the places weighing scales, at least digital weighing scales are made available, so that is not a problem. Only the timing at which it is being done and how well it is recorded. Because sometimes, we have done studies where the labor room weighing and then immediately when the baby comes to NICU, there is a difference. So that also, at least in the facility levels, they should not have. So that is another thing. In olden days, of course, we were talking about other issues, that standardize the weighing scales, match the weighing scales, accuracy and all. But nowadays, with the digital weighing scales, that should not come. But these digital weighing scales also, from time to time, their accuracy needs to be checked. Sometimes the cell may go down and all that. And calibrations. So I'm talking from my practical experiences. So I'm just saying. So weighing has been always an issue with us, and I have always compared the weighing which was done in the labor room, and then when they come to NICU, what is the difference between that? If that happens in a medical college or a facility-based care, then what to expect from the community? So that is one part. And second thing, that community level, I do not know. Tamil Nadu said they had some weighing scales, but I am not aware of anything. We want digital weighing scales are nowadays available at the district hospitals. Again, the calibration, the same issues are there. But at the peripheral level, home visits when they have to do, they don't have a good portable weighing scale. And whatever weighing scales we have, that has a minimum reading of 100 grams. Ideally, for a newborn monitoring, especially when we are talking about preterm, low birth weight babies, when we want to monitor the sick babies, we need better quality of weighing scales. So that is one request I want, that you please make sure that we have a good weighing scale which can read minimum of 10 gram a case. Because in newborn, all of us we know, weighing is a very sensitive issue, and that even when the health workers are there and if the digital scale is there, because the direct readout comes there, so it will be easier for them to monitor. And nowadays such portable weighing scales, to my knowledge, which can be easily taken from place to place, are not available. Earlier through TANSI, that is Tamil Nadu government, we had those B-balance scales. But even that have gone, the digital scales are not available. In fact, I can go on this, but weighing scales also require some improvement. So please look into it. Otherwise, my simple other solution is these kitchen weighing scales, digital weighing scales are available. And they have good accurate readout, especially from Salter and such standard companies if you get. They read up to 5 kg. And those kitchen weighing scales with flat ones. And on that, if you can keep it clean, then the babies can be read out. And all that we require for the neonatal purposes, even up to 3 kg, it comes fine. Then rest of the things can be monitored with it. So that is just one suggestion. And at community level, even the weight taken, first weight, if it is taken within the 7 days, even that can be considered as birth weight. It has been given as the data also. But the only thing is they have to write down on which day the weight was taken. Suppose on the 3rd day it was taken, 3rd day this is the weight, or 5th day if it is taken, that is the weight. So up to 1 week we can take. So that is about the weighing scale. But in short, we want accurate weighing so that the babies can be monitored well. And nowadays, Ashas, at least in all the states where Ashas are there, we have designated visit days. Those who are delivered in the hospital, 6 visits are there. Those babies who are delivered at home, 7 visits are there. First day, within first 24 hours, first visit. Within next 48 hours, another visit. Then 7th day, 14th day, 21st day, 28th day, and then 42nd day. And depending on the condition of the baby, the Asha worker can take more visits also. And they are incentives. So that is also another thing. So follow up they can do. And a simple thing like weighing, if we can do, a lot of things can be achieved, depending on that we can. Then another, yes, counseling, you said. So that also we said, antenatal itself, we should sensitize. And in counseling also we have been saying all the messages need not be given all the time. Then the question of time comes. We don't expect everything to be given. Only, they won't remember, it's not necessary also. All that we are saying is, when they come to antenatal period, you just have to say, soon after birth the baby will be put to your chest and the baby's breast milk will start. Whether you get the milk or not, the breastfeeding will start. Because the first question the family members always say, still the milk is not there, what to do? And we say, you put the baby to breast and the milk will come. And they say, let the milk come and then we will put the milk. So this simple one or two messages, and if the mother is right from the beginning antenatally ready, soon after birth they are going to put the baby on breast, that gives a lot more compliance. Especially now we have got mothers only one or two babies, and especially primary, if she doesn't know, even the labor itself is a overwhelming experience for her. And then suddenly they put the baby on breast, she doesn't know how to hold her. All that is a big thing. So, antenatal period, that message. Same thing reinforced just before the delivery. Now she being ready, they will put the baby. That's what you say. Then, when you are actually taking the baby and want to take up other messages, then you say, now they will be putting the baby to rest and means care, how to hold, how to position, how to take the help of other members, what to monitor, all those things. Right in the beginning, if you say on the very first day, if you don't hold the baby will sleep, and all that negative thing, they really get rejected. And then they say, we don't want to do it. So these are all the simple tips for the counseling. And for visit in the facility, in the community, if you consider, this is not too much of a work. Because in a given situation, at a given time, not more than 4 or 5 low birth weight babies are there. You agree with me? No.
They will put for many other things also, along with it.
Along with that, but this one sentence we are saying, make sure that you mention this. I am not saying we are having hand washing, but it has to be gradually built up. Everybody doesn't come quickly well. But at least as far as breastfeeding KMC is concerned, one sentence to be added, that is all. And perfectly know the situation, it is easier said, madam, doing is difficult, but after doing it, some of the times we are able to say. We have to build up their confidence, otherwise if we all the time say, no time, there is no time. So these are the things to come. Then early skin to skin contact is something I think we should universalize. It should be done. Soon after birth, we have been repeatedly saying, even before the call starts, you immediately put the baby, rather than putting the baby down on the bed thing or taking the baby in the tray, just immediately put the baby on mother's side. Because the pleasant cord length may not be there to immediately reach it to the chest. And then by the time you have the delayed cord cutting, and you cut the cord immediately, quickly dry the baby and transfer the baby to the chest. And if mother is not in a position to hold it, that is another area. You already prepare an alternate care provider who can be available to you to do it. Birth companion or family member who can be there or anything. All these we have now got the provisions, but somehow we are not utilized. So we have to study then why it is not being done. These are all some of your previous cycles we can improve this. Then transport is another thing which can be easily doable. At least in the facilities I have been requesting, even in the workshops I said, when you are transporting when you are discharging the baby and sending them home, make sure you put the baby in conveyor position and then send them home. If you have taught them how to put the baby in conveyor position, how to hold it safely, that builds up their confidence. So next time when they bring the child to you, you can request them to bring it in this position. Even if the baby is term baby also, make it resolve. In Western countries, I have seen, they make the nurse go up to their car and then put the baby in the seat, baby seat, put the buckle, only then they can take it home. You cannot say, oh, I'll take it to my car and put it. She makes it sure that you have it. Similarly here, we must make it sure that they are put in the chest. And I don't think it is a difficult thing. If we develop it as a habit, it should not be difficult. Anyone of you can comment on it. I will go on speaking. If you have any problems, you let us know. Whether it is doable or not, you let us know. Because they have shown you, even in the crowded Bombay trains also, their mothers are able to carry the babies. Preterm, low birth weight babies. So at least we should try. And I will always tell you, there will be definitely 3 to 4 situations where it may not be possible. There will be 2 to 3 situations where it is easily possible. But in between there are 3 or 4 situations, depending on how well you have motivated them, they will do it. They will tilt on this side or that side. Never start only with the negative points first. Start with the positive points. Somebody, if they have been able to do it, show them that this is possible. If they are not able to do it, it's not necessary, everybody will not be able to do it. So these are all the few small, otherwise we will never be able to make further progress. As it is, we are worked over and we appreciate it. Some things are where we have to make progress. So that is another thing. And of course another thing we have been now experimenting, we do not know how far we will be successful, this mother support groups. If you can form mother support groups who can come to the facility, and even when you do not have time, if they can come for say 2 to 3 hours per day, they can form a group whom we can orient, they can see some of the cases, then they can advise the mothers whether you have been breastfeeding today, whether you have hold the baby on case or not, like that. So this is another experiment with this works. And in villages also, this ICDS program is there. See that whether we can create such groups. I think then we will take up other things. Otherwise, we will not stop.
Thank you, madam. I think Dr. Dodo is there and he will share his experience from Delhi.
Good afternoon to all. Thank you, Dr. Aditya and organizing environment delivered to give some suggestions. As I am working in a peripheral setup for the last 35 years, and as a pediatrician for the last 23 years. I am working in Sub-Regional Hospital, Sub-District Hospital, Gandham District for 17 years, and I was in Rayagada for 1 year, in Bajpur also 1 year, and Kandamala 1 year, during my pediatric specialty. And what I found, Madam Sajjani has described all the points, and Dr. Rogers, what is happening, and what are the barriers he has described. As we feel, the parent counseling is very important. And after delivery of a baby, a preterm or normal or low after baby, most of we observe in our district, the baby is not taken up by mother but by grandmother. And when we go around to see if a baby is okay, there is no problem, and there does not need any social newborn care, then mother is delivered and she is feeling sick. That mentally, the grandmother will tell breastfeeding is not proper, breastfeeding is not proper, and so when another part is empty, the grandmother will be giving the child and the mother will be there. So there is breastfeeding, and mother's breast is best shortest breast position of baby. So everybody from doctor up to the ASA, everybody should have attitude, knowledge we have to give to the ASAs and government, the NMs, and our doctors should take some time, even staff nurses, those who are trained, nursing officers, they should take time for counsel to the parents as well as their in-laws. That is more important. Regarding, as I have seen some cases, the children come for 3 to 4 days time brought up and there is severe hypothermia. The KMC emphasis on vital part and mother's stress is that surface during the So the KMC is definitely has important role of survival of the child and proper newborn care. And not everybody should ventilate the knowledge up to the hospital level. I have day before yesterday, as a Kaya person, district Kaya person, I visited 6 health and wellness centers. There are community health officers, very good community health officers. They are having good knowledge and science given and without breastfeeding, new research and everything there. But as we find, every discuss when a baby is normal delivery, the grandmother and mother does not want to stay at 48 hours, which is a victim. And as advised in our program, 48 hours stay, if they would have done, and in that period, they would have given proper counseling regarding breastfeeding, regarding positioning, regarding KMC. So, and they will not attend 48 hours in the hospital, so that will be carried out in their home. Home-based KMC will be carried out, and that will be observed by the ASAs during the home-based KMC visit. So that is more important. So I don't want to tell you more. This is every corner and NSM in setup, they are trying their best for training of the from ASAs to the doctors and pediatricians as well as all doctors. All MBS doctors should know how KMC. And KMC should be a criteria, a subject in pediatric practice in MBS setup. So that then they come to the pediatric setup and they should know, they should train others. Thank you all.
So thank you, good afternoon everybody. So my view is in the antenatal, during the antenatal checkup, we should have IEC, TB, where the newborn, how to do KMC and all will be going on. So that mother will be motivated from that time. And that can continue, repeated banging with the mother, that will help, I think. And as Madam told, I have seen in SCV also the labor room weight and SNSU weight is much difference. And we are doing ICMR project also. The ICMR people cannot know what weight to put because already in the bedded ticket the weight has been put. So there is a much discrepancy that has to be corrected. And for the motivational part, motivating and all, the Rotary Club, Lions Club, they can be made to help. That in KEM hospital I have seen, they are motivated and one day in a week they come and they give counseling to the mother. That we can do. And another thing is the labor room sisters and SNSU sisters and antenatal care sisters, we can train them and they should remain there for a long time. Because if they have repeated shifting and changing of nurses, then whatever nurses we have trained, they again will be changed. Then it is a difficult part in our place to do that. That should be there that at least 2-3 years they should be fixed. And if at all they will be replaced, at least 1/3 will be replaced so that the new 1/3 will be trained by the older one. That if it is possible, it will be better.
Thank you, madam. In my view, I think nothing is impossible. So, as it is seen that maximum low birth weight babies are dying in Odisha, from my state of view, I want to say a few words that this should be a movement, this should be a commitment, and everybody should learn about KMC. it should not be restricted to health department. Now time has come, it should be spread to all over the community, including the community leaders, the school and mass education department, then W&CD department, all the departments and other PRA members. Everybody should be aware about the KMC because this is the only method in which we can reduce the preventable deaths. We are not talking about that 700 babies, 600 babies, 900 babies, why they are not survived. But we should think about these 1800 babies, 1500 gram babies. And as Madam has pointed out those about weighing scale, as I am in the system now and I am working in a government setup, I mean planning and policy making, I found that we have given supplied these digital machines up to delivery point level, that means up to sub-center level. So it is not a problem, but only thing is that attitude of the staffs, whether they will weigh or not, and they are using the weighing machine or not. But digital machines are available up to delivery points till now. Yeah. Second thing, and to answer that question, that we are strengthening the HWCs, that is Health and Wellness Center. So now the provision is that there will be a telemedicine center at HWC, there will be the spoke, and how will be at district hospital, and they can show the essential discharge baby. Suppose after 15 days the baby is discharged to a village, the baby is not able to do follow-up at essential. So they can come to that nearest HWC where these digital weighing machines are available and trained CHOs are available. Now, utilizing that facility, they can connect to the district SNSU and they can weigh the baby, they can see the delayed milestones whether it is there or not, and any growth problem that can be seen from that by CHO. So these facilities are available, but only thing is that we have to utilize that facility, we have to strengthen that facility. So I am very much thankful to KMC Foundation, specifically Sasibani Madam, for arranging this conference here, because this ignited our service providers. Mostly the faculties from medical colleges attended this conference, and I thought most probably they have enriched their knowledge on KMC and how to roll it out, because that is important. Everybody know about KMC, but how to roll it out, that is a challenge. But it is very easy, and this will be very helpful in future. And I think in Odisha we shortly are going to reduce our neonatal mortality by doing KMC. Thank you, madam.
Just one more small request. Every unit should have a medical audit system. We are collecting the data, but we are not sharing with all the people who are help to collect the data, and they don't even know how the data is used. If we collect minimum set of data, share with them, discuss with them, and then go ahead, then they will feel that it is important.
One is we have to make it simple. And the more data points you want, the more challenging it is. So come up with some 5 or 6 data points. And the second thing what we found in Canada is benchmarking was very, very helpful. So if I'm in District A and you're in District B and you're doing better than me, I'm going to want to know why. And then I'm going to want to do better than you. And that really, really helped us improve. So set up a system which may be helpful.
So even if you say that, for example, KBC, so how many babies were made and how many babies were followed? Even 1 or 2 such points also you can take. But that will go ahead and you share it with your nurses, doctors, everybody. Now, so many places they are doing everything because no data available. And data they are collecting, but again it is not available. That irony is there. Everybody says, yes, we collect all the data, but where it goes for yes.
Not converted to data.
Exactly. So that is exactly what another is. There is, in the beginning I didn't want to say that, but that is very much needed for us. Every facility must have a perinatal data audit, And that first year he put up on the board. This man, we were so many verticals, we had so many desks, we had so many speakers, we had. And whatever the causes were there, at least some cross points. And you have discussed it with your obstetricians, you discuss it with your nurses, discuss it even with your anesthetists. That really helps. We have been doing it for 30 years and there were so many fights. But we have to go through that and we have to come. So data is another very, very important thing. Whatever you are collecting, you share with others, discuss with others, and then find out what next and what. That will give the incentive for the others to collect the data also for the next time. Otherwise, oh, we are writing people back. So that is another important point.
But rightly, Nalini Madam and Madam said that the benchmark should be there. So one have to fix the benchmark on which you should be collecting the data and then disseminating the data to the higher level and to the state level. That is most important. Another thing I want to give, another important thing I want to share, that at the community level we must enlighten the ASAs, Anganwadi workers and the PRI members, SLG groups. We have to do a convergence. We have to, in local language, we have to make them understand what is the importance of KMC and how to do it in local language, so that they will understand it better. And then because in our place, ASAs are involved in so many things. They have to participate in animal control, they have to BSLE days, they have to see the nutrition, malnutrition, all those things, and malaria control, etc. And so many things are being monitored by ASAs and AIMS. So if we not only the health workers, if we involve the SLG groups, particularly PRI members and the SLG groups also, they will be a pillar of strength to us to facilitate popularizing this mother care and how to take care of the newborn babies at home, all the essential newborn care. All these things we should impregnate in the mind of those SLC and the PRI members, because they are the persons from the family in a village or in a community. So if they will be aware and they will be convinced, then I think a mother will get 100% support from her elders and her family members. And apart from that, during the antenatal checkup, these ANMs who are conducting the antenatal checkup, for each antenatal checkup we must keep some benchmarks. During the first ANC, this should be told. During the second ANC, this thing should be told. During the last ANC, I think the mother care concept should be put into the mind of the pregnant ladies, so that they will understand what is immediate skin to skin contact, that they will understand after the delivery, the baby will be immediately put to their chest, and then only they will accept the thing. Otherwise, they have got a notion, no, the baby should be kept in a different place, in a separate place. These things, they don't have in mind, because it is, I am telling you from my practical experience. Whenever in our cases, we want to put the baby to mother's place, mother will first resist, no, I will not keep the baby there. So then they should be prepared right from the antenatal period, and in this, not only the Anganwadi workers, even because they will be coming once to the LHS or STS or CSC to a doctor. So all those doctors must be made aware about this important, all the essential newborn care, all this skin to skin contact, and the mother care immediately after. So all these things you should keep in mind and accordingly. So that please don't forget that. At least for Kangal Mother Care, we celebrate every 15th of May as an International KMC Day. And on that day, whichever nurses who have done some good work, nothing more, at least one certificate in front of others will do, that is also a type of work. So at least that, and if all of them are doing good work, give a no
problem. There is no competition. So the question of politics and recommendation and all is not there. Yeah. So, but that we don't do it all. That is why I am saying. Anyway, thank you very much. And I think we thank you everybody for that. And finally, at least on behalf of KMC Foundation, I want to thank each and every one of you. I don't know how to put it formally. I'm not persuaded, but you have treated us like family, friends and members, and given us a very, very warm facility here. And each and every one I thank. Yes, what is it?
I think we are more talking among the pediatricians. I think we should concentrate on physicians, because they are the best persons to influence any mother, because they have a prolonged contact from starting from the first trimester. So physicians should be sensitized. Maybe inclusive programs, we should know physician, we talking to the physician. It should be a perinatology conference rather than a pediatric conference. Number two, madam, yesterday in the workshop I was telling, since Madam is well known, a popular figure in the country, Madam can influence the government of India. The government of India is announcing breastfeeding week celebration and newborn week celebration. Why can't be a KMC celebration at the national level? If it is a national level program, 50% of the people will just observe what is really KMC. That is point number 2. Point number 3, NHM. Usually they support the malnourished child. When the mother stays with the baby for 14 days, they support with incentive of 100 rupees per day for the mother to spend. This is the government GO is there. Since we take all these vaccine treated local drugs, so intra-uterine malnourished baby, the same scheme may be adopted for the mothers who is there in the NHC for 15 days. At least some incentives to the mother in the form of NRC. That will definitely reduce the economic problem which occurs in the family. We are talking about early discharge. The early discharge may be from the hospital side or from the family side. If the family compulsions are there, the mother has to go to the family fast also. I think these are the things we can influence upon the NHM madam. Whether these kind of incentives can be given to the episode. That is very important. That's what I feel. Madam was talking about ambulatory counseling, the physicians are there. I think it should be a team counseling rather than a single person. Whenever they come to the ambulatory here, we can just inform them that, because they all know the ultrasonogram, all mothers are undergoing ultrasonogram nowadays in OG department. That means most of the physicians, they know the weight approximate. It may be 1.2 or 2.5, something like that. So it's either you can sensitize that your baby is going to be 2 kg, she needs another one facility after birth. These are the things we can tell the mothers so that they can accept it. And last, any program is successful if it is a public demand program. It's not the observation or pediatrician. The public understands everything. They will demand. Give the daily everything. That is the point we should derive last. Thank you.
That we already did. Regarding incentives, I wanted to say 2 things. Incentives is a catch-up program, short-term program, according to me. The moment you stop the incentives due to some reason, the program collapses. If you build up a program through education and awareness, then actually it sustains. So that should be our goal for. Yes, sir. But supposing tomorrow you are not able to provide food, immediately the mindset is, oh, they are not able to provide it. Hasn't that really for us? I have faced this in family planning program. There are clean transistors, so even the person who got sterilization are going to use it. So
I say that we need the PG best food to the
so you appreciate them in the public, that is the, but don't be, at least personally this is my view, considering this thing. For everything we can't be an incentive, cash incentive or some kind of incentive. Incentive can be in the form of appreciation, awards, and genuinely if they require something, naturally at that time you help them. But don't call them incentive. Because once you give it to one person, another person demands their right, but they don't. These are all some of the experiences we we have gone through. Anyway, that is one part. You have made a valid point, and as you said, obstetricians we have started evolving. You have realized that. And second thing about the perinatology conference, we have done that experiments also. Now ISOPAB is there. Then even through NNF also perinatology meetings were tried. But then what happened? I may not say those things, but due to some reason or other, obstetricians take over, pediatrician again goes back in the background. So it is better. We call them, but ideal perinatology somehow doesn't happen still. But we can try. There is no harm. Thank you. Yeah. Thank you very much. And so, one immediate.
Shashwari, thanks to you and your team. The many physicians work at multiple levels, many hospitals to try and implement KMC. I just have a suggestion, like Total COVID campaign is a success in India, thanks to Amitabh Bachchan. Could we rope in some celebrities to talk about KMC and bring in awareness at multiple levels? People tend to listen.
We have been trying since past 6 years. I will end the sentence there.
The younger generation of celebrities.
I will show you. See, this we have tried. If you give them money, they will do it. And we don't have awareness. Unless government takes it over.
Priyanka Chopra, she's a lot of money.
Right? Anybody who tries, I am ready to help.
She didn't have a pre-term baby as well.
I tried with Karishma Kapoor, I tried with Alia Bhatt, I tried with somebody else. I don't know. But we are not able to reach them. That is another. Somebody is influenced.
Television can give 2 minutes, something like that, and we want to that we can write.
The moment these advertisements come, people they get up and go. So, one-to-one, repost with these statements that helps. Otherwise, we have been trying this for that.
Thank you, madam.
Thank you very much. And I thank all the volunteers also who have given us their services and each and every person. Our please, please.
Now I would like to request Sasi madam to present a memento to Dr. Brothers, please. And Dr. Gowda.
Bring.
Now I think this is time for valedictory session. So I would like to invite all the organizing team members to come to the dais. Dr. Tapos, Dr. Jagdish, Dr. Meena, Dr. Tanusri, please come. Dr. Pankaj. All the persons who are present there, please come. Actually, this is a great opportunity for us that Madam Sasivani is there. Please. Meena Madam, please come. And actually, we have planned this only within 2 months. So thanks to Sasivani Madam and her team. And I want to present a memento for Sasivani Madam. Please, President NLF Odisha is going to felicitate Sasivani Madam. Please. Now on behalf of organizing team, we want to recognize few of the volunteers who have worked relentlessly day and night to make this conference successful. So I want to invite Dr. Abhilash, Mr. Abhilash from UNICEF, and President NNF to felicitate Dr. Abhilash. Abhilash Kumar is working as in UNICEF. Madam, ଏଠି ଅଛି ଅଛି ନା ଏଇଠି ଅଛି ବା ରଖିଛନ୍ତି ସେଠି ଆଉ ଏପଟେ ଚାଲନ୍ତୁ ମ୍ୟାଡ଼ାମ ପାଖକୁ then I want to invite Dr. Sambit Jana. Kindly come to the dais and receive a memento from President Madam, please. Then Nihar Ranjan Jana from UNICEF, please come. Nihar. Then Gitanjali Behra, she is also from NHM, Koraput. She helped a lot in during this conference. Anusri, please come. Then Dr. Hiralal Nayak, I think he is not there, he is from NIPI and he helped us a lot in during this conference. I want to invite Mrs. Anuja Behra from PPP cell NHM. She coordinated the NGO workshop and helped in this conference a lot. So thank you very much, madam, for your kind support. Our organizing secretary, though he could not join us during last moment, he is Dr. Jagdish Sahu. Kindly come over here and receive a memento from Sasiram. We have got very good anchors during this 2 days conference. Dr. Shruti, please come over the dais. She is from AIMS, doing SR in AIMS, and she has done it well. So kindly come and receive a moment from us. Dr. Shruti, this is Bheneja. Then Dr. Ankita and Dr. Manasa from PGI Capital Hospital. Now I want to invite the man behind the show, our office assistant Umakant. Umakant, please come over the dais. He is a silent worker and done everything in a right time, in right way. And he is there with us in IAP, NNF, IMA, every activity he is there and he works silently. Then we have got our DEO from NHM, Prabhat, Mr. Prabhat. Madam, आपकी रही ले, So thank you everybody for nice.
Now I would like to invite Dr. Ritanjay Mishra here to sing a song which he has sung during the workshop during workshop. And all of you give special cheers to Dr. Aditya Baba. Special cheers. Thank you very much, Dr. Aditya Baba. Thank you. And I would like to
So this is the.
Now she'll sing the song.
Huh? Go.
Take care. Transport team.
Okay. Thanks though.
Hello. Thank you very much, Sarvankarani, Society Madam, and all the organizers for giving me the scope to stand here and express whatever feelings I have collected during these 3 to 4 days of this training and this conference. And I have converted it into Odia song. I will utilize it for awareness of our grassroots level workers. So this song is in Odia. I don't know if it is understandable by some of you, but please excuse me. Kongarumara kotha kahibi mona dei sabu suna, ai mona dei sabu suna. Ei kotha tiku mone rakhile je sisura jibana dhanya, ai sisura jibana dhanya. Namasa purvaru janma hele sisu kam ojana rahe, 25 gram kam ojana rahe. Kongaruma pori jatna naba pai, taku darakara pade, are taku darakara pade. Chuaku rakhiba ma chhati bhitare, khali dehe ma chua, are khali dehe ma chua. Dui janku je ghorei rakhiba, mone rakhiba jeha, are mone rakhiba jeha. Chuara usnata bajai rakhe se, chuara usnata bajai rakhe se, chuara buddhi adhika, are chuara buddhi adhika. Ma rakhirate amrita samana, ekatha tumane rakha. Ma khiratai amrita samana, ekatha tumane rakha. Kahiba kongarumara jatana, kahiba kongarumara jatana, garbhavastharu maaku, are garbhavastharu maaku, buঝେଇବା garbhavastharu maaku. ପରିବାରର ସମସ୍ତଙ୍କୁ ବୁଝେଇବା, ପରିବାରର ସମସ୍ତଙ୍କୁ ବୁଝେଇବା, ସାହାଯ୍ୟ କରିବେ ମାକୁ, ଆରେ ସାହାଯ୍ୟ କରିବେ ମାକୁ। ନିଶ୍ୱାସ ପ୍ରଶ୍ୱାସ ରକ୍ତ ସଞ୍ଚାଳନ, ନିଶ୍ୱାସ ପ୍ରଶ୍ୱାସ ରକ୍ତ ସଞ୍ଚାଳନ ହୁଏ ଯେ ନିୟମିତ, ଶିଶୁର ହୁଏ ଯେ ନିୟମିତ।
want to request Dr. Sasivani to felicitate to more faculties. Dr. Tanushree Sahu, please come to the dais. Tanushree and Dr. Usha. Dr. Usha, please come to the dais. Or you can receive. Anybody can receive for mementos for them. So this is the Thanksgiving ceremony. Madam, Shruti, please receive it. Madam, vote of thanks.
Introduce one more faculty member,
Yes.
Dr. Arif. Please come here. Dr. Arif Kora is another person who has come for the quality improvement. You want to tell something?
First of all, I thank Madam. First time I met the Madam during my residency days. My thesis was on KMC, and from that topic, I with KMC become my interest, and I done so many research on KMC. Today, Madam has invited me for a workshop. It is great pleasure. And it is a warm welcome was given by the Odisha team and hosted to them. So this is my first day today in Odisha. So I'll be here for the 2 days workshop.
Thank you, Dr. Arif. We'll be meeting you tomorrow in the workshop. So now we are coming to the end of our academic extravaganza. So many workshops, and then 2 days conference. We are coming to the end. With this, let me thank my heartfelt thanks to Dr. Sumita Ghosh Madam and her team who has visited such a long distance to encourage us. And my heartfelt thanks to KMC Foundation of India and the Managing Trustee Professor Sashivani Madam and her whole team who has wholeheartedly is there for us, enriching our knowledge, conducting the workshops and encouraging us in so many ways. So my heartfelt thanks to KMC Foundation and Professor Sashivani Madam. Again, I thank our LNA President Sushma Nangia Madam. She has also come such a long way, spent so much time with us, and really it is a very encouraging and enlightening session she has taken. So I thank her for that. And I must thank our AIMS BBS Bhubaneswar team, the director, the dean, and Dr. Tapas Som and his team here, so that because of them only I could successfully conduct such type of workshops and conferences here. So my heartfelt thanks to the AIMS team. I again thank to NHM, Government of Odisha, MD Madam, DFW sir, and his team members here. And because of their help only such a gathering could be possible here. So my heartfelt thanks to NHM team. Again, I must thank to our IIP President. My heartfelt thanks to IIP President, Odisha team, Secretary, and all the organizing persons. And also again, it will be incomplete if I will not thank the UNICEF persons from UNICEF, Dr. Vivek, Dr. Meena Madam, Dr. Rajesh, and all the team members who have supported us like anything to make this conference successful in all way, and the NIPI representatives, also all the state, national, and international faculties. My heartfelt thanks to them. All the participants here present, MO specialists, staff nurses, NGO staffs from the districts who have participated in the workshop and the conferences. My heartfelt thanks to them. I thank from the core of my heart to the uncles from AIMS and Capital Hospital, Shruti, Vaneja, Ankita, and Mansa. They have done a wonderful job. by successfully conducting the sessions and the entire organizing team. And also, my heartfelt thanks to KMC kids and their parents who have come all the way to inaugurate, to present with us for the inauguration for all our workshops and conferences. Then I must thank the Kmccon team who has helped us in the registration process and other things. My heartfelt thanks to Kmccon team, and also the food we have taken, the food catering team also I must thank the catering team of the AIMS, and the team was regulated the transport of all the delegates and also our participants. Last but not the least, I must thank the Indian Oil Corporation Limited, the Director HR, Mr. Ranjan Kumar Mahapatra. He has supported us in our endeavor. With this, let us conclude the session. And last but not the least, I must sing a song. कभी अलविदा ना कहना, कभी अलविदा ना कहना, कभी अलविदा ना कहना, कभी अलविदा ना कहना, चलते चलते बस यूं ही तुम गुनगुनाते रहना, कभी अलविदा ना कहना, कभी अलविदा ना कहना. Thank you. Let us meet again and again. Thank you.
Gujarati we say.
All the participants and committee are requested to come to the dais for a group photograph and national anthem.
In Gujarati we say. અમે અમારા ઘેર જઈએ બે રામ રામ લો, અમે અમારા ઘેર જઈએ બે રામ રામ લો, કોઈ ભૂલ્યું ચાલ્યું માફ બીજું શું કહીએ, કોઈ બોલ્યું ચાલ્યું માફ બીજું શું કહીએ. It goes on. And it only says we are going home, take our Ranga, and whatever we would have said or done something, explain.
मैडम आई जाओ एक ज बलराम जल्दी मैडम आई जाओ તમે બી તમે नीचे जઈને લઈ લે
से फोटो उठाता था अपना था
वो
भी तक आइले कोन तो मासी रे
बोली कोना काय रोटी रे बनावो ये ओरिसा बोले कोना
आज के कालिया गुजराती बात है
घणीवार ना खबर
जल्दी
बलराम
खत्म करिया
यस
चलो सखी
गुड बॉय यस ऑल ऑफ यू रेडी प्लीज
गोटे मिनट इट हां यस यस आई एम स्टेइंग हियर ओनली
यस बराबर हो गया
जगन्नाथ चलो सखी
चल सखिया में दर्शन करिबा नीलगिरी कालिया को, केउ सुरपति बेसा करियाछि गिरिवर दोलिया को, से जे मुख तोरा सिरे सुना सुता केरा केरा, से जे मुख तोरा. श्री जगन्नाथंक दर्शन करिबा, श्री जगन्नाथंक दर्शन करिबा, खाइबा छड़ा तुलसी करी शिकालिया कुरे, दर्शन करी शिकालिया कुरे, मन होई जीव खुशी से तो जग कालिया, दया राखी सबुकर पर से सग कालिया.
So let us sing the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा तब शुभ नामे जागे तब शुभाशीष मागे गाये तब जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
चलिए मैडम नाइस बहुत अच्छा